Dr. Khan, it is 9 a.m. on Friday, July 19th. If you're ready, I think we can go ahead and start.
Yes, we are ready. We call the meeting to order for the Patient Protection Commission. This is July 19th, 9 a.m. I'm Ikram Khan. I'm the chair of the commission with the Nevada Department of Health and Human Services. Mr. Filippi, thank you. Can you have us take a quorum call?
Yes, Dr. Khan, thank you. Joseph Filippi for the record. Commissioners, if you can go ahead and just state your name, or sorry, just let me know if you're present today when you hear your name, just so we can make sure a majority of members are present. So starting with Commissioner Jalen Bahunian, are you here?
Present.
Thank you. And Commissioner Walter Davis? Okay. Commissioner Wendy Simmons? We can see.
Present.
Sorry.
Yeah.
Perfect. Thanks, Wendy.
Present. Thank you.
Commissioner Bethany Sexton?
Present.
Thank you. Commissioner Andrea Peterson?
Present.
Thank you. Commissioner Marilyn Kirkpatrick? I'm not hearing her yet. Commissioner Flo Khan? Hearing her yet. I believe, is Walter Davis, are you on yet?
Yes, I'm here.
Perfect. Thank you, sir. Awesome. And then Chairman Khan? It looks like thank you. We have a majority of members present. I know that Dr. Bio-Curry Wenschel, she said she would be unavailable till about 10 a.m. today, so she plans to join a little bit late. And then once we hear from Flo Khan and Marilyn Kirkpatrick, we'll announce their attendance when they join. But we do have a majority of members present, so we can go ahead and continue.
I'm here, Joseph.
Oh, thanks, Marilyn. We'll mark you present. Appreciate it.
All right. Thank you. Just moving along with our agenda, that concludes our roll call for now. Next item is the public comment. Regarding the public comment, we have 3 minutes for each individual to submit their public comment. Joseph, could you proceed and see if we have anybody online?
Yes, thank you, Dr. Khan. Again, Joseph Filippi for the record. This second item on the agenda is to offer the opportunity for public comment. No action may be taken upon a matter raised under the public comment period unless the matter itself has been specifically included on an agenda as an action item. To provide public comment over the phone, you may join the meeting by dialing 775-321-6111. And when prompted to provide a meeting ID, please enter 467-104-852#. Comments will be limited to 3 minutes per person. Persons making comment today, we ask that you begin by stating your name and spelling your last name for the record. So if you wish to give public comment over the phone, you can press *5 to raise your hand. If you're joining via the Teams platform on your computer, just click the raised hand feature at the top of your screen. So going in order of hands raised, it looks like we have Nilesh Gokul. Please go ahead and unmute yourself and go ahead.
Good morning. Thank you. My name is Nilesh Gokul, G-O-K-A-L. I'm a family physician based in Southern Nevada and president of the Nevada Physician Wellness Coalition. The NPWC is an autonomous, independent 501c3 nonprofit that formed in 2018 in Northern Nevada by a group of physicians following the death by suicide of 2 of their colleagues. The NPWC and the Nevada chapter of the American College of Physicians have submitted to you a proposal aligning with the Patient Protection Commission's objective of addressing healthcare workforce shortages in our state that supports the removal of invasive mental health questions for physician licensure and credentialing applications in order to better recruit and retain a healthy workforce and in turn better serve our growing population. As you know, Nevada ranks 48th in our nation for board-certified primary care physicians per capita, which relates to a burdened healthcare system correlating to really tragic data demonstrating that physicians have one of the highest rates of suicide of any profession, that 1 in 5 physicians plan to leave their current practice, and 1 in 3 plan to reduce their hours, and 62.8% of physicians experienced burnout in 2021 versus in 2020 at 38% from a Mayo Clinic report. We also know that burnout is associated with a higher risk of medical errors and reduced health outcomes. Our proposed changes align with the AMA and the Lorna Breen Foundation and have also been adopted by 23 states across the country, directly combating the impact of stigma surrounding mental health and improving care access where and when it is most needed, so that caregivers, specifically physicians, are best equipped to provide high-quality care to their patients. In addition, these states receive direct funding, which we propose as a line item in the Nevada state budget, to support the work of an autonomous, independent nonprofit such as the NPWC. Over the course of 3 years, we have reached 19% of the Nevada physician workforce with a 50% increase in registrants year over year, building a culture of safety, empowering and educating self-care, and creating a sense of belonging with trust and connection to a community, all of which directly combat burnout. These proposed changes will support the statewide goal of retention and well-being of the physician population, which will in turn positively impact patient safety, health outcomes, and access to care. Thank you so much, Commission, for your time today and the review of our recommendations.
Thank you, Dr. Gokul. Appreciate your time this morning.
Thank you
Moving
very
on,
much.
we still have Kenneth, is it Kunk? Kunke? Go ahead.
Yep, Kunke. Good morning, Chair Khan and members of the Patient Protection Commission. My name is Ken Kunke, Kunke. I am a practicing pharmacist in Nevada since 2003. I am representing the advocates for lower out-of-pocket cost and patient access. We are a work group of people in Nevada that consist of healthcare professionals, healthcare and patient associations, and businesses. Recently, we submitted a PDF to you concerning pharmacist benefit managers, or PBMs. The PDF highlights the lack of transparency that occurs with PBMs and how this can lead to increased out-of-patient costs and lack of access to medications for patients. The overwhelming majority of prices paid at the pharmacy counter are based on price points established by these PBMs. They control the data. Throughout the country, states have passed laws to create transparency in this section of the drug supply chain. Unfortunately, Nevada is way behind the curve. In the PDF, we highlight the problems that PBMs are causing and recommend 2 proposed bill draft requests that will help with this issue. We are looking forward to working with you and answering any questions that you may have. Thank you so much for your time.
Thank you, Kenneth. Appreciate your time this morning. If there's anyone else who wishes to provide public comment, please press *5 if joining by phone or raise your hand through the Teams platform. Dr. Khan, I'm not seeing any additional hands raised.
Okay, so we can proceed with the next item on the agenda that we have is for approval of minutes. I presume everyone has had an opportunity to review the minutes. Do I have a motion to approve the minutes?
Dr. Khan, this is Marilyn Kirkpatrick. I'd make that motion.
Thank you. Second?
Dr. Khan, this is Wendy Simmons. I second.
Thank you very much. Any opposed? If none opposed, we'll consider them approved. Moving to item number 4. We have a presentation on Nevada Medicaid and policy opportunities to address provider workforce shortages. We have total allocated time for this is about 30 minutes, 20 minutes for the presentation, and about 10 minutes for Q&A. Just a reminder for all my colleague, the commissioners, we have a pretty tight agenda. So we'll do our best to complete in a timely manner so you can all return to your regular work. So let's proceed. Joseph, you want to proceed, see where we are with the presenters?
Yes, thank you, Dr. Khan. Yep, we have Administrator Stacy Weeks here from Nevada Medicaid. Stacy, whenever you're ready, you can go ahead and share your screen and begin, please.
Thank you, Joseph. Good morning, everyone. I'm going to go ahead and share my screen. All right. Here we go. Hopefully everyone can see that. And just a reminder, I have a hard time seeing all of you. So if Joseph, please flag for me if something comes up or if there are questions. I know we're going to hold them to the end, but if something goes wrong, just jump in and interrupt me. I'm going to go
Sure.
ahead and share the first slide. All right. Okay. So today we're going to talk a little bit about high level as much as I can in 20 minutes about Medicaid. It's a very complicated program. I think all of you are familiar with that. But we're going to try to hit the high points this morning and kind of ground us in Nevada's Medicaid program, and then look at, I think, probably the hardest financing in any area of the state budget, which is Medicaid financing, given some of the federal share and all the other pieces that we have to do on our end to really fund the program. And then we're going to look at provider reimbursement in Nevada as compared to other states and as compared to Medicare. We're going to look at, I think something that's really important for us as we look at the budget is getting better value for our taxpayer dollars in Medicaid and some strategies around that the state could do like other states. And then I just wanted to end with some considerations for all of you this morning. I know you guys are putting together your recommendations and I wanted to end with that. But let's go ahead and get started. So Nevada Medicaid is a taxpayer funded program. And I think that's really important to remember. It's something that it does not come totally from all federal funds. It's not a grant. It truly is a program that's funded partially by the state and partially by the federal government. And it's a taxpayer funded program. And so when we impact the financing of Medicaid, we are impacting tax programs in the state. It covers about 1 in 4 Nevadans currently. It was 1 in 3 during COVID. So we are currently looking more at 1 in 4. And nearly half of the people covered in Nevada are children and families. It also covers 1 in 2 births in Nevada. And it's something to remember is the payer of last resort, in which that means under federal law that if the individual or family is covered by another insurer, Medicaid is not the first payer. We have to first bill the other payer and then Medicaid picks up the rest if the member and family are covered. Nevada Medicaid, as you can see in this table here, makes up about a quarter of the payer mix in Nevada. And when I say payer mix, this is when we look at coverage in the state by population and by payer. Most of the state is covered by employer-sponsored insurance. This is our ERISA plans. And the unfortunate thing for all of us here today is we can't touch those plans and we can't touch the rates in the program, right? This is a federally, the program is ran at the federal level and has the federal authorities impact that program. And as you guys know, employers buy health insurance for their employees, but it's the most of the pie. And so most providers, for the most part, except for some providers probably in our rural areas or areas where there are a lot of behavioral health needs and other issues, most providers are paid by commercial insurance. The next one is Medicare or Medicaid, as you can see, like I said, a quarter, and then Medicare, and then followed by individual market, which you guys probably know as the exchange, the Nevada Health Link. Is in that market, or any plans that are sold outside of that market directly to someone, for example, who might be self-employed, who doesn't have employer coverage, but they buy their own coverage. And then that smaller bucket there is military. And then the uninsured in our state is roughly around 11%. It kind of teeters from 10 to 11%. We still haven't quite gotten past that. Medicaid creates policy and quality standards for services and really can, and we've seen it in many other states, drive performance depending on how we pay providers, because the business model behind payment really does impact performance and outcomes. Real quick, just a reminder, Medicare is not Medicaid. I'm still explaining this to my 90-year-old grandfather all the time. Medicare is managed at the federal level. And so when people call us, we have to say, so I'm so sorry, you're frustrated, I can't help you, you have to call CMS. Medicaid is managed jointly by us and CMS, but really when someone has a need or an issue, they call us at the state level. And so it's a very different dynamic, right, than Medicare in terms of customer service and really feeling like it's easy to address something. I think it's probably feels easier for people because they know that the people they're calling are in the state. Medicare is funded by federal government and consumer premiums, whereas Medicaid is funded partially by the state and partially by the federal government, and it's at no cost to the consumer, the coverage is. And that's because these are our lower income families and individuals. It's also Medicare covers 65 and older, And it really offers a benefit set that's truly just really a basic healthcare benefit set. It doesn't really pick up long-term care services, which is the majority of the cost besides pharmacy in Medicare, which unfortunately those costs are shifted to the state under Medicaid. So that's really, I think, some disconnect there. Seniors don't understand often that their Medicare plan is not going to help them with assisted living or services in the home to help them stay in their home or with the nursing facility. We do have members who are on both programs that we call them our dual eligibles. And people with disabilities, these are usually people with disabilities who cannot work, and they're people who are 65 and older are typically on both programs. And like I mentioned, it's because they need some of those long-term care services or community supports that Medicare does not cover. All right, let's dive into my favorite topic is financing Medicaid. It's probably the most important. When we look at Nevada Medicaid specifically, every state has a different, what we call federal and state share of the program. The federal share in Nevada is 60% on average, and then the federal and the state share is 40%. So for every dollar that we bill, the feds pick up 60 cents and we pick up 40 cents. In total right now, if you look at our approved budget, we have about 9.4 billion in federal dollars that we are billing to the feds, and we are picking up 6.3 billion of those costs. Our total Medicaid spend in Nevada is 15.7 billion, and that's what we are approved for the biennium. I just wanted to note that only 3% of this entire spending goes to what we call administrative expenses and to operate our program. This is, if you've ever worked in a program or even at a hospital or any program, it's usually 10 to 15% is your administrative cost. Medicaid is very low. I mean, I think that's just Nevada's way, right? We like to spend as much as we can on the services that we provide. But right now our program is 3% administrative. The rest is really going to provider reimbursement and covering that coverage and program that we provide Nevadans. So when we look at the biennium for 23 and 25, I just kind of want to back up for a second and look at the bigger picture before we dive into talking about how do we spend Medicaid dollars. It's important to remember that as a whole, our state budget is 53.4 billion in approved spending. So when you remember the pie, earlier I mentioned the roughly $15.8 billion for Medicaid. There are other things that the state has to spend revenue, and we'll talk about where this money comes from in a minute. But when we look at our expenditures, a lot of them already go to HHS, which is our Health and Human Services. It's about $21 billion, and that's public health. It's also child welfare. It's a lot of our programs that sit under the department that we are within. We make up about 75, and we will probably be closer to 80% of that total bucket of spend on Medicaid. So I just kind of wanted to give you guys some context. Education, as you can see, is much lower. I mean, it's still a big piece of the pie, but it's at 33%. And that's 17.8 billion. It's only a little bit more than what we spend in Medicaid, but as a whole in our state for human services and healthcare, we spend more from a budget perspective. And so when we think about budget and lawmakers think about the budget and the governor, they often have to think about these needs. So I just want to remind everyone, when we start adding money to a pie, or it's often we don't have money to add, and we're taking from other areas that are just as important and meet the needs of our state. So when we look at revenue in the state for the biennium, the Medicaid is when we look at this, so take a step back. So the big piece here to notice is that most things are funded through general fund dollars. And for Medicaid is that federal fund, which is the light blue, and the general fund, which is that purple. And we'll talk about what really drives the percentage of the general fund in the state. But all of these revenues are used, all of this is used to pay for the services to Nevadans that we just, as part of that pie I just showed you. The sales and use tax in Nevada makes up the largest share of our general fund revenue that we get to spend for the biennium. And that's followed by gaming and business taxes. So when we talk about spending or needing more money for education, Medicaid, and HHS, any of the big things that the state provides for Nevadans, we really have to often think about, do we increase those taxes, right? So I just want to and I know that that's a bigger conversation for Nevadans, but just a reminder that all of this must be driven here. And those are the hard decisions that often lawmakers and the governor are faced, because we all know everyone is tired of taxes and there's a lot that we already pay, right? And so we just thinking the bigger picture here. So when we do budget planning for sessions, so our next legislative session, the other thing in Nevada, for those of you who may not know, is that our legislative sessions, when we make these decisions about spending, are every 2 years. And so our next one is next year, and that's why we're working on budget bill drafts with you all. You have 3. But we're already in that planning mode right now. And to increase any of our spending, right? So we are approved what I showed you earlier, that 15.8 billion in base spending. If we're going to increase rates significantly or really make major changes, we have to go back to the legislature and the governor and ask for additional budget authority and funding. And that means we have to get more of that general fund revenue. It's not, we can't get more federal money without putting up that 40% of the state costs, right? So we have to have that on the table. And this, like I mentioned, occurs every 2 years, and we are planning that now. And everything we're doing right now is confidential until released. But as you can see, it's a pretty tight timeline. I think a lot of our stuff is actually due next month. Provider reimbursement rates. So before we dive into the reimbursement and how it works in Nevada, I wanted to talk a little bit about delivery system, because it does matter in terms of how people receive services, but also how providers are paid. So the historic way of paying for healthcare is a fee for service. So a provider pays a service, or provider delivers a service, and then the payer, which in this case is Medicaid or the insurer, pays the provider directly per service. It could be an encounter rate, but it really is, you do something and I pay you a fee. It really rewards volume. So if someone is trying to drive their business and increase money, what they need to do is obviously provide more services. So it's really that volume over value. When we look at value instead of volume, this fee for service structure is really tied to volume. There is some risk to the state budget in this. There's no utilization management. And often we find that there can be fraud and risk in this kind of program. And so that's why we do have a SIR unit, is what we call it, that oversees some of that and looks at whether or not providers are actually providing the service they need, and that we are paying them appropriately. Most of our rural individuals, our children, families, and adults are in fee for service, but soon enough in 2026, rural families and individuals and adults will be in managed care. But right now they are fee for service. Our waiver recipients this is our home and community-based service program. They are in fee for service. Our age, blind, and disabled benefit and Medicaid, those individuals are in fee for service. Right now it's about 72% managed care and 28% fee for service. That pie is going to change next year, or 2 years, in 2026, when we move into managed care statewide, but not for the entire population. Our waivers recipients and age, blind, disabled will remain fee for service. So it's going to look more like 85% maybe managed care. Our managed care system is what really we look at. It's not perfect. I'm never going to say it is, but it is the best we have for really looking at actually overseeing the program, ensuring that there are provider networks, that we actually have some oversight into what's going on. And it's really looking at managing cost, utilization, and hopefully, right, the big key here is quality. MCOs develop provider networks, and we pay those providers through the managed care plans. They usually set their own rates, but I just wanted to note, because I know there's a lot of risk and concern about managed care. There is a way, and we are looking at this, is a way to actually set a fee schedule and make sure that none of our managed care plans pay lower than fee for service. And depending on sort of how that looks, we may have to tie that only to certain types of providers where we know there's risk that they'll be underpaid. But for the most part, we are looking at setting that fee schedule as the bar minimum for managed care plans. And then last but not least, there is another type of delivery system that can overlay both fee for service in some ways, but mostly managed care, is a value-based payment design. And we're looking at that right now through managed care to reward providers for lowering costs and improving outcomes instead of just paying for volume. We look at types of provider rates. So for the most part, for most providers, they're familiar with that base rate. And that's the majority of what we pay in Medicaid. So that's why it's the bigger piece of the triangle. It's the typical fee schedule or rate per service based on a funding level. It could also be a per member per month, a monthly payment, but it is the base rate that a provider gets. Now, a supplemental payment is typically what we see for hospitals, primarily, or some other groups of providers under federal law that we're allowed to pay a supplemental payment to. The supplemental really supplements that base rate. You can do it annually or quarterly or monthly, but really is saying to a provider, we are going to supplement your base rate. And usually it's either a local government that pays the state costs of that and we draw down federal funding, or like a provider tax. We'll talk about that in a minute. And right now we have a lot of these programs for our hospitals. And then our bonus payment is that tiny little, it looks tinier, but it is something we could do more in Nevada, and other states are using this to really incentivize care and the business models. Like you could do a bonus payment on a rate, for example, and we have recently for rural access. So if someone provides a service in a rural community, we pay them a little more, a bonus, to incentivize more activity in our rural communities. Or if it's a pediatric service, we'll pay a bonus or incentive payment. So those are the type of things that we look at. We do have what we call a quadrennial rate review process in Nevada. It occurs right now every 4 years. I will tell you, it's very time consuming on our end, and it's a pretty large report. I think Joseph may have sent those around to everyone to read, but if not, we can send the links too. We are just finalizing our behavioral health report, which will be coming out soon, and looking at some other behavioral health rates that we did not look at before. But it really is advisory. Often people think because a rate was told, because the study found that a rate needs to be increased, and that we just automatically increase the rates. But that's not how it works, because it is advisory and we're also not funded. Like I mentioned earlier, we have to have budget authority to have state dollars to draw down that 60 cents for every dollar of federal money. So when we see a finding, we make those recommendations often in our governor's budget recommendations, or we hope that lawmakers or others will bring legislation to follow those recommendations. And then we also, like I mentioned, we have to seek that approval, but it's every 2 years. And so that can be challenging when we know that there's a rate need. And so we have to wait 2 years to get that funding. So we are looking at something when we have a sizable surplus, which in our budget account, which is not always the case. But if there is one, we're looking at ways that if we have authority to cover the service, is there a way that we could do some minimal, smaller rate increases in the second year of a biennium before session as a way to address an access gap? And the way we're tying that to authority is through the new federal access rule. I won't dive into much here, but there is a very a good case here that this helps us stay in compliance with access. And so we might be able to look at increasing rates, but it would not be significant rate increases like the ones that I think actually drive workforce, right? And so that's something to just remember. Just to give you guys an idea of what we've seen so far, these have not been around forever, but I think we have had 3 of them at this point. So the results are often mixed depending on the provider type, and our rate is on par or higher than the 5 states when we look at some services, and then others were lower. It does vary, and sometimes it's really hard for us to compare apples to apples because some states don't pay the same type of fee, or they have a different structure for their base rate. It's really, or sometimes they do bundled rates, or they bundle services and pay one rate. So it's really hard to compare across states, unlike Medicare. And then also we do not get enough data from providers. So often we put out like notices, we ask for cost so we can actually compare, are we paying at least the cost for the services? And often we do not get a good sample size. So that's kind of why our results from the QR are really truly informative, and they're really limited to the data we have available. So when we look at, we did an analysis recently of our rate gaps, what I call them rate gaps. So where we really know we have significant need, and align them where there are also access gaps. So we have an access monitoring plan for the federal government. And we looked at those. These are the buckets of types of providers that really truly had gaps that were significant, along with significant access needs. Some may surprise you, some may not. But as you can see here, dentists, audiologists, substance use providers, APRNs, physicians still have issues. Primary care, pediatrics, psychiatrists, and OBGYN specifically are some key areas for us that we need more access in. And then our physician assistants. I would note though, those stars here are those providers that did get a bump, a 5% bump last session. Again, 5% may seem small, but it was hundreds of millions of dollars. So none of this is cheap, right? But it was a step in the right direction. It was part of the governor's proposal and the legislature approved it. I would note though, APRNs are now paid in parity with physicians, so that also improved their rates. So they are now paid the same as a physician. And then I just wanted just to clarify, I know there are a lot of providers that might be listening and being like, I'm not on that list, I should be. And I totally get it. And we hear about it all the time. We haven't been able to assess every rate. And we haven't have the capacity to do a rate assessment for every provider. We often hear from a lot of providers though, especially anesthesiologists, PT, speech therapy, occupational therapists, radiologists, urologists, nephrology, clinical psychologists, and behavioral health outpatient providers is all struggling with reimbursement. So I just wanted to give them sort of a shout out of areas we know we have significant gaps in access and rate challenges. So I did want to step back before we dive in. How do we increase rates and some of the things around that? When we looked recently at a report that came out of Kaiser Family Foundation, and one of the indicators nationally is how are you doing in Medicaid as compared to Medicare? This actually surprised us. We are 7th in the nation for high Medicaid reimbursement as compared to Medicare. We pay right now on average 96% of Medicare reimbursement. The highest is in Delaware at 118%, and the lowest is in Rhode Island at 37%. So this we all kind of paused and we saw this report and looking at the data. And it made us wonder, then why is it that everyone feels our rates are not enough? There are two things to think about. The cost differential. So healthcare in Nevada, the costs clearly must be higher. That could be the reason. And so even though we pay like Medicare, which typically is a better cost-based and often rate and is typically higher than Medicaid, the costs just generally are higher in Nevada. Or there's a huge rate differential in commercial rates. For example, hospitals may feel that Medicaid is really low because their commercial rates are really high. And so there's that cost differential may be just larger in Nevada than it is in other states. So there's two things to think about, because when we look at Medicare as usually the indicator, we are still below it, but we are not as low as a lot of other states. And it's what's interesting about this, and the reason I wanted to put these both on the same slide is because Nevada never ranks in the top 10 for anything. And here we are on reimbursement, but the last in health. And I know that's bleak for a Friday morning, but it's the reality. We are spending a lot of money, but we are last in the Western region. We're 48th overall and 39th in healthcare and reproductive outcomes, 49th in coverage and access and affordability, and 51st or last in healthcare quality and prevention. All right, so let's say we want to get to 100% of Medicare. There are some studies out there that show when states get to 100% or a little above, they have seen some minimal increases in access. I will say there's mixed studies out there. There's also studies that states have done significant rate increases and seen no change. And that's typically in the rural areas, and that's no surprise, right? It's not just about money. It's about really people move their families to live in these communities. It's bigger than just the rate. It's often what is it like to live somewhere outside of, and especially in rural areas. So when we look at increasing provider rates, what does that mean? So like I mentioned earlier, if we're going to increase Nevada Medicaid rates, we have to increase the amount of state general fund dollars spent on Medicaid medical expenditures. So again, we have to come up with that 40 cents for every dollar that we want to spend to draw down federal matching funds. So again, it's not a grant. We don't say, hey, feds, we need 30 million or 2 billion this year. We actually have to, for every claim, submit what we call a CMS 64. And we show that we paid the 40 and they paid the 60 cents. So it's really, really complicated, but it's not a grant. And so it requires legislative action because these are real dollars that we are spending, and it's an entitlement program. So if we go over what we've been spent, I have to make up that money somewhere else. We have to go back and do contingency or make cuts to programs. So again, we would be increasing when we think about, so how would we do that? So we have to look at what's our revenue, our general fund revenue, how are our state taxes doing? Do we increase the rate, or is there a good economic impact already occurring and we have a little bit of extra general fund? Now, often I'll be real. I've worked in Medicaid, unfortunately, a very long time. And even in other states I've worked in, it's typically not Medicaid that extra general fund money goes to. You know, it goes to education and other things. So just being very real that it's not the first thing that the money's spent on. There are other ways to increase revenue, and that's a provider tax. And the hospitals did that recently, and we'll talk about that. Or we can do spending on other state functions. We would be reducing those. So that's the arrow down. The other option here is to reduce education money, reduce other areas, or we look at total cost of care. This is where I like to go because I don't have to worry about trying to find new revenue. I have to think about the longer picture of we just need to spend better and how we do things so we can actually start to bend the cost curve or at least plateau or at least get better value for every dollar we're spending. And that usually is the way we start to see some room to spend better and spend more. But it takes time, and these things are not easy to do because they're changing business models. And then, or we just cut services, right? We reduce spending on services. There are only a few levers. It's rates, it's cutting people eligibility, or it's cutting services. And I promise you, none of us, I think, want to do that. Recent examples of last session, the increase in revenue came from a hospital tax. And thanks to the private hospitals, they all agreed under state law, if there's an agreement, there has to be a survey of the hospitals, they agree to it. We can collect a tax revenue and it will be spent back on supplemental payments. We talked about that earlier to pay hospitals. Those supplemental payments, when you take out how much they're paying in tax, it's over 600 million this last fiscal year. We think it will be higher this next fiscal year. And it's for inpatient and outpatient hospital services. I would note that thanks to the legislature, Senator Titus and the governor, as well as private hospitals, we get to include up to 15% of that revenue each year for community behavioral health. And when you match that with federal money, it's about $100 million. And right now we're investing that in children's behavioral health in response to the DOJ. So that's where we were able to come up with new revenue. And it was really exciting. We also saw new provider rate increases, and those came from other portions of the pie. There was about 200 million in biennium and new investments for provider rate increases. I mentioned earlier the 5% for physicians that happened, and there were a bunch of other skilled nursing facilities got a pretty significant rate increase as well. I know I'm trying to watch time, but just real quick, I mentioned this hospital tax was a big deal. It's very exciting. We got it stood up and appreciate the partnership with the hospitals. But I just want to note provider taxes are not always successful. There are always winners and losers. So while some will do really well, not everyone's going to get the money back, and we can't promise that they will. That violates federal law, and I can't match it with Medicaid dollars. So it's just important to remember some of our smaller provider types, they may have more losers than winners. So these things are kind of a delicate dance, I would say. But thankfully, our private hospitals, there was enough money in this system and enough money that we can make it mostly winners than losers. I mentioned earlier investments that drive value. I would just say that when we look at the studies and what we know drives value, if you have limited dollars and we need to prioritize, we really need to look at community health and clinic services. We have to get away from everyone going to their ER for their basic care. That is so costly to Medicaid. And if that is the only place they can go and they can't get the basic appointments to even get a physical, get a flu shot, or get whatever it is, and check if they're sick, they need to go see someone. Instead of going to our ER, we really need to be investing in that primary care system in this state. And I recognize that it's hard anymore to just hang out your shingle and have your own primary care clinic. Other states are looking at what we call systems of care, and where hospitals are investing in primary care providers and outpatient services that we can pay more on. I would just note our hospitals with the provider tax, we can't really put more federal money into those supplemental payments. They are capped out at average commercial rate for managed care. That's what they're getting with those supplemental payments. And they're also getting the Medicare upper payment limit. So we've hit that on inpatient and outpatient, but what we haven't is if they open primary care and things like that, we can pay them more under the primary care side. It's a professional service. Outpatient behavioral health is another one. In-home services, therapies. We know these reduce institutionalization and hospitalization, which are all costly. School health services, all of these here. I would just say that we need to think about getting upstream with our investments and treat things earlier, improving access to cost-effective care. We need to reduce that need for ER. And there is a study out there that showed every $1 invested in primary care over time results in $13 per savings for that individual in the healthcare system. So when we look at value, I try to put this slide together in a way to kind of explain what's the difference between volume and value. So our left side is fee for service, our right side is value. And I looked at something CMS in Minnesota put out, so that's kind of where this came from, but I added some interesting stuff for Nevada here too. But on the left side is really that fee for service model. And there's really not much happening here in terms of value. It's again, just volume. You can tie fee for service, which we are doing now, to quality or outcome. So for example, we are now going to be providing for some psychotherapies and other psychology and services, we're going to be tying a rural bump, a bonus payment. So it's really tying that outcome that there's more services, even through telehealth in our rural communities, right? That's the outcome we want. We're tying the rate to that and providing a bonus. There's shared savings and shared risk models. This is really our accountable care organizations that other states are doing and seeing some improvement, not just in money, but really value to the outcomes, right? We are ranked so low in the state. We really need to think about how do we pay differently to get the better outcomes that we need. And now I won't go through all of these, but there's actually partially capitated payments to providers where they have a little more risk in the outcome, but they are rewarded with the savings. The savings just don't go to the managed care plans, right? So typically now when someone's healthier or they don't get services, right, that's the other side of it, there is the idea that the health plan saves the money. These shared risk models and capitated payments allow the providers to win when they're seeing better outcomes. So those are the type of things I think we really are trying to do more of in this state, and we could use a little help in that area. And so just to end on this, why I think I've said it, it really does promote better outcomes and how we pay for it. It improves care coordination. We can pay for that differently. The fee-for-service system doesn't really drive care coordination. Instead, it really does drive a high-cost care model. I mean, it's no surprise that the ER and, trauma and other areas are the biggest driver of revenue for our largest systems. And so, and that's really hard when we have limited taxpayer dollars. So trying to run quickly here, I know time. But before I stop, I don't want to just make everything about reimbursement. I just want to remind everyone there's enough studies out there that shows you have to have a multi-pronged strategy to improving access to care in our workforce. Rates alone don't solve the problem. And we do need to attract providers and to come at the cost. And we can't just waive every rule and requirement to billing and hope that that's going to drive quality. There are some requirements that are needed and oversight. And so we can't just throw everything out because we were just desperate to get providers. So there's a balance. We do need to look at graduate medical education, indirect medical education. I know Mercer's going to present on that later, but there is opportunity here. The state has never truly invested the state share and done a Medicaid model in the state. I think broadly it's a smaller model, but mostly it's been driven by local dollars and not state general fund dollars. And it's something I think we should be thinking about if we want a statewide strategy. Loan repayments are important. We've seen that work in other states, but really tying that to people staying right in that community. Other states do that and it is successful. The other thing I would say, and I apologize, I didn't spend as much time on this. I know people want to talk about reimbursement, but we know that billing Medicaid is hard, and that is something we need to change, and we need to make it not about administrative burden. There are things we need to prevent fraud and improve quality, but there are things we can do better on our end, and we are working through some of these things now. One of them is creating a centralized credentialing organization. So you don't have to be credentialed by every managed care plan and the state to enroll in Medicaid. You can go to one-stop shop and everyone honors it. So we're working on that, and that should hopefully be live next year. We're also looking at streamlining prior authorizations across managed care and fee-for-service. So providers, when they do a prior auth, the form looks the same, the process is the same, the timelines are the same. We do recognize some prior auths need to be removed. There are some that they're always going to be approved. Then why are they there other than to have an administrative burden, right? To slow the process. And that is not what we want. We want people to get the service they need and the access to care. So I'll stop. I think that's almost it. So yeah, just to end on this, I know you guys know this, but nothing's free. And at the end of the day, we have to find the taxpayer dollars to pay for this. Healthcare is growing in our country, and as you can see, it's clearly growing in our state. And we hear this all the time. Taxpayers can't afford to keep up, right? So how do we balance all of these needs. And we know we have a growing senior population, and that is one of the biggest seniors in the disabilities population. They have some of the more expensive costs. They are a smaller population, but they are driving more of our costs in our program. But we have to balance those needs with how much taxpayers can afford. State general funds are limited, and there are other costs to the state that are important. And then you pay for what you get, right? How you pay, it's kind of what you get. And we need to look at using our limited state funds to really drive better value and outcomes and more cost-effective care. And I really encourage you guys to consider accountable care and value-based payment models if you are looking at reimbursement and helping us ensure that we're getting the best value for the dollar that we're investing in the state. And that's it, Joseph. So I'll stand for questions.
Thank you very much, Stacy. Really appreciate that. Was quite thorough, and that's what was expected from you, obviously. I have a couple of comments, and then we can open up for discussion. You already mentioned you get what you pay for. We are at the bottom of the list on quality. So you know where we stand on that. Number one. Number two, we all also know that we're leaving dollars on the table from the federal government. Number three, talking about reimbursement, almost none of the extended care facilities like nursing homes, long-term acute rehab, are taking Medicaid fee-for-service patients because they don't get paid much. And this has been debated for years in the legislature, et cetera. The result is the cost of care shoots up. The patients sit in the hospital 3, 4, 5, in one case 14 days because no facility wanted to take the Medicaid patient. In fact, facilities have assigned 3 to 4 beds only total for Medicaid patients, if at all. So there are multiple challenges, not for discussion today, but we find money for education, $1 billion here and that. Healthcare, from my point of view, is crucial, literally crucial. And I think the work done on healthcare is not enough. It's not a priority. We patchwork, Band-Aid, give 5% here and 2% there. There has to be a comprehensive approach to it. I'm sure you guys are working on it. So that's my little observation on it. We will open up for questions, and Joseph, you could kindly monitor the hands up of the commissioners. We have 10 minutes for that, so we can proceed.
Thanks, Chair Khan. This is Joseph, and I apologize. I'm off camera. My computer forced a restart on me, so I'm joining by my phone. But want to open it up to commissioners to go ahead and ask Stacy Weeks any questions they may have regarding this topic. Feel free to just go ahead and state your name and ask your question.
Hi, this is Walter Davis. Thank you, Commissioner Stacy Weeks, for a thorough overview. I definitely appreciate it and learned a lot from it today as well. You may have mentioned this in your presentation, but I just want to confirm on the split, the 60-40 split, is that just unique to Nevada, or is this how it is across other states as well?
Thank you. That's a good question. The 60-40 is what we get on average. It's called our FMAP, but every state is different. So it's based on our per capita income. I'm sorry, it's Friday morning. Per capita income. So if we are doing good from a economic standpoint and people are, their salaries are going up, the federal share goes down. So for in a state like Mississippi, theirs is much higher. It's like in the 70% of federal money, and they pay the 30. In some states where the economy is doing really well, it's more 50-50. And the federal government will never pay less than 50. So we were closer to 64, 65 during the pandemic because we were getting additional federal enhanced funds. But now that that's gone, we're back down to 60. So it can fluctuate, which can be challenging on a state budget, but it's not, you don't usually see huge fluctuations in per cap income or whatever. Most of the time it's little small increments and changes over time.
All right, thank you. And then just a tag along to that is the 3% administrative cost, is that on average, is that normal?
It's lower, I think, than most states. Where I come from in Minnesota, it was closer to 10%, but yeah. It is lower, but we're not asking for more administrative funds. We need more money for people that we serve, but thank you.
Right. Right. Thank you.
Anyone else?
Commissioner Flo Khan, feel free to
Yes,
go ahead.
thank you. Thank you. First of all, great presentation. So much good information in here that I think will help guide us. But I had two questions. The first is, are you seeing, you said in your presentation that oftentimes you didn't have enough data from the commercial plans and others to make some real comparisons. From the all payer claims database, Bill, are you getting more information as a result of that to help kind of drive some of the decision making that could occur, particularly around rates and other things? I'd be curious to hear that first, and then I have another question.
Yes, thank you, Commissioner. I love that question because we are excited about the APCD because once we get that data, we can really do a true assessment by provider type. We're just in the process right now of getting that stood up. So I think the regulations are also going through. So I think that's not going to be up for another year or more.
Okay.
But once that's up, we will have and we can actually track access and look at things very differently in our state. So we're very excited about what could come out of that data and the use of that. So good question.
Okay, perfect. And then my other question that I had was, you mentioned, there were some administrative burdens that you see could be very beneficial in just improving access. And I guess my thing, and you mentioned two of them, obviously the creation of the centralized credentialing and then the streamlining of prior authorizations and stuff like that. Do you, as an agency, are you finding that you're going to need legislative changes to accomplish some of these goals, or is this something that you can do on your own?
We can do that on our own, and we have started it. I would say that some of the things that we might need that could really help us do better on prior authorizations, like some other states are doing now, with various vendor and consultants, but they're looking at studying prior authorizations and how often they're happening and really tracking them and having sort of a dashboard and to know like, oh, that one is always approved 90% of the time, let's remove it. We don't have I would say the capacity or the capability to do that right now. And there are other states that are also looking more at population health management. And I think that could really be used in a way to relieve some burden. So I think there's sort of that capacity to do some of that work that we would love to do that we just can't do yet.
Anybody else?
I'm sorry, just following up on that. When you say you can't do it, is it because of lack of funds, or is it because you don't have statutory authority to do that?
It's not statutory authority, it's capacity and authority to get the vendor support we need and expertise.
Okay.
It's very it's stuff that other states are really using to drive and really monitor their MCOs in a different way. But drive by value and data. Thank you.
Got it.
Thank you. Joseph, you see anybody else hand raised?
Yes, Dr. Khan. We have Bethany Sexton and Marilyn Kirkpatrick.
Okay.
Hi, Stacey. Thank you so much for the presentation. Two questions. On the 3% administrative dollars spent, is that inclusive of administrative dollars held by the MCOs?
No, so of that, there is an administrative spend, but it's always it's about 9% and 8% right now of the total spend in managed care. And that's about 7 billion of that pie. Most of our spend is fee for service. It's our higher cost population.
Got it. And then second question on the GME and IME that you mentioned in terms of expansion, can you just speak a little bit more about that and any opportunities you see there?
Yeah, so I know Mercer's coming up, so I don't want to steal their thunder, but when we look at other states, I think obviously for budget reasons, the state hasn't always invested state general fund to cover the cost. So we've relied on some of our local universities to fund the state cost. But if we were able to actually have a fund to invest money, right, annually into that state dollars, we could pull down costs we could pay for salaries, all the indirect costs to actually have medical residents on staff for providers. And a lot of states are using that model to drive residencies in other parts of the state. So, if we did a Medicaid funded program, I think broader than what we're able to do now with the limited funds, I think we could expand it. I know UNR and others are looking at it.
I think we should let Mercer address that during their presentation in the interest of time. So Commissioner Kilpatrick is on.
Thank you, Dr. Khan. And Stacy, first and foremost, I want to say that's probably the best comprehensive short Medicaid presentation I've seen in 20 years. So
Thank you.
kudos to you. And it was in layman's terms for everybody to understand. Just a couple of things. So, and I know we've already made a lot of movement, and sometimes I feel that legislation needs to let you do your job. As opposed to hamstring you on things that are out there. And it's not the end all be all on the rates, but maybe you could talk about just your thoughts. I think that we're moving, I know at least in the rural areas, you've been moving to maybe help hire someone that can help do all their Medicaid billing in, different counties, so counties could work together. I know the FQHCs, we've been working to get them paid a little bit higher on the primary piece. But I still think that we might need to modernize our billing process for one, just to kind of keep up with the terms, and that's IT, and then really maybe target, and I like that you put that in there, that we target the Medicaid reimbursement for value and access to service, because as long as I was in the legislature for 12 years, we tried to do incremental stuff, and it doesn't always make a difference. You can't see it because you're doing so much that not one thing is making a difference. So, but I didn't really see behavioral health on there. Is that because you've done it in a separate component? So food for thought.
Yes, we've done a lot of work with behavioral health, and we have that funding. And we just finished our QRR report, so we didn't have all that ready. I didn't have it all ready this morning for the slides, but there are needs, and we did present that to Interim Health recently. Some preview of that data. There is a need, especially outpatient. We did, though, at IFC, which is our Interim Finance Committee, right, increase rates for residential treatment centers to $800 a day, doing bonus payments tied to value. We're with that new tax money that we have. So that 45 million I mentioned that we can match with federal money, it's about $100 million that we are using to drive better behavioral health outpatient care.
Thank
you very much. Joseph, how are we doing with time, and which other commissioners?
Dr. Khan, we have one more question from Commissioner Peterson.
Yeah, I just have a quick question. You commented a little bit on loan repayment, that can help with providers. I know that there are some loan repayment, different things available in the state. Are you aware, is there additional needs regarding that, or?
Yeah. I think it's just never enough. And I also think it would be nice if there was, I know that there's a lot of those things going on. So sort of that coordination of like, where are those loan repayments going? And I know that there's one with the treasurer's office, which is really great. But I think maybe just making sure whatever we do is tied to people staying in the state, because sometimes they get their loan and they leave, right? Or they serve 4 years and they leave. It's sort of like, we maybe make them stay 5 years after, right? They're done with their residency, those types of things, where we actually, Arkansas did that. I know Alaska's doing that, and it's a way to keep people in those rural communities or parts of the state.
Thanks.
Thank you. I'll just make a quick comment and maybe a question, is that in terms of the availability of physicians, which are just challenged for pediatric intensive care unit services, neonatal intensive, this is a highly specialized area, and any consideration for their reimbursement situation. They work out of the hospital system, but that is the challenge, getting those specialized people in these 1 pound babies and 2 pound babies, or critically ill young children in the intensive care unit. Did you hear that?
Was that a specific question for Stacy, Dr. Khan?
Yeah. Is there anything being looked at for that particular specialty area of pediatrics?
I mean, when we look at the data right now, we are not sending children out of the state for those services. The out-of-state services that go out of state are really not surprisingly maybe, but glasses and blood tests and things like that in lab. But it's not that we don't have the need in some of the areas of the state, but I think in most states struggle. It's a natural thing. We're not going to have specialists in every region of the state. But we do not see a huge out-of-state access issue for that.
All right. Thank you.
Mm-hmm.
Okay, we can proceed then. Thank you very much for your
Thank you. Thank
very,
you for your
very
time.
valuable information.
And thank you
So
guys
we
for your
can-
work.
Thank you. So we can move on to the next agenda item, which is item presentation. Let's see, where are we?
Dr. Khan, this is Joseph for the record. I think the next
Yeah.
presentation is item number 5.
Yeah, 5, that's
presentation.
correct.
Yep, on Nevada Medicaid.
Medicaid considerations from the provider perspective. Again, allotted time is 30 minutes, 2 separate 10-minute presentations and 10 minutes Q&A.
Thank you.
It should
Dr.
be
Khan, I believe we
20
have a
minutes.
representative. Yep, we have representatives from first up from the Nevada Hospital Association and the Nevada Rural Hospital Partners. And then we'll have a second presentation as well from the Nevada State Medical Association. Each
All
one of
right.
these presentations, I believe, has a 10-minute allocation.
Right.
Hi, good morning, commissioners. Thank you again for having us back at this meeting. I am Blaine Osborne, president of the Nevada Rural Hospital Partners, and I am proud to be joining Patrick Kelly, who is president of the Nevada Hospital Association, who will get us kicked off here.
Good morning, everybody. I wanted to spend just a couple minutes and a couple slides showing you the historic perspective for Medicaid reimbursement to hospitals. As Administrator Weeks pointed out, there's a base level of payment by Medicaid to healthcare providers. And this graph demonstrates our base Medicaid rates for about the last 21 years. If you notice, 0 is in the middle of the chart, not at the bottom. So you can see that we've had rate cuts, we've had rate increases, cuts, increases, and everything. But in the end, over the last 21 years, we've had about a 5% increase in reimbursement from Medicaid. That's not 5% a year, that's 5% over 21 years. This next chart incorporates the last chart. The bottom line that you see in the dark blue, purplish color, that is the chart you just saw. And the line above it, the lighter blue, is the increase in hospital costs over that same time period. So you can see there's a significant difference. So over the last 21 years, we've seen about a 57% increase in hospital costs, while Medicaid rates only increased by 5%. So there's a big gap that occurred. So Medicaid has addressed this as as Administrator Weeks commented, that through supplemental payments. And basically either hospitals pay a tax or a government entity pays a tax to draw down additional Medicaid dollars from the federal government. You probably have heard a lot about the private hospital Medicaid provider fee program. The reason it's called the private hospitals is because these supplemental programs don't generally apply to every hospital. They apply to groups of hospitals. So for the private hospital program, government hospitals are not part of the program. They have other supplemental programs that they participate in. So this private hospital includes nonprofits like Renown, Dignity Hospitals, and the other hospitals in the state like Sunrise and the Valley Health System. So I want to just take a moment to thank Director Whitley and Administrator Weeks and her fantastic team at Medicaid, because pulling off this private hospital Medicaid provider fee program was huge, and it's incredibly complicated, and they did it in a very quick amount of time. So about this time last summer, we were taking a vote, and 42 private hospitals in the state agreed to tax themselves. And the way this works is those tax dollars are taken by the state and sent to the federal government to get the federal Medicaid assistance percentage match. And so we did that, and that has generated a substantial amount of money. So in state fiscal year 24, we're expecting a net benefit of $362 million for those 42 hospitals. And that is a big improvement. Now, I do want to caution you, we're in a situation where we're just starting to kind of get that money in and get adjusted. To get this money, the hospitals had to pay a tax. before they got any money back. So there was a lot of money that had to be paid out. So we're just now getting to the point where the amount we're receiving back is more than the amount that we've been paying in taxes. So it's flowing well, but a little bit of a struggle for a few months, especially for a few of the smaller hospitals. But this doesn't really solve the total problem because there's still a lot of unreimbursed care out there. So we have people who can't pay their bills, and we also have a gap between what Medicaid pays us and the amount that it actually costs us to provide the care. So if we go back to state fiscal year 2022, Nevada's largest hospitals provided more than $1.2 billion on unreimbursed health care. And the reason I'm using that is under state law, hospitals over 100 beds have to report data. The smaller ones do not. But I want you to understand that every hospital in the state provides unreimbursed care. So when I'm talking about this 1.2 billion, that's the low end of the number. It would be higher if we had the data from all the other hospitals. So we'll do a little math here. If you look at the 1.2 billion that we provide in unreimbursed care, and you take out what we're going to receive in state fiscal year 24 of the 362 million, we still have a gap of $838 million in unreimbursed care. So while things have improved dramatically and we're very appreciative of that, I just want you to know that it doesn't cover everything. And when we talk about getting Medicare rates, that is a huge improvement over what we've had, but we still lose money on Medicare rates. Those rates do not cover the actual cost of care. So just in summary, over the last 21 years, we've had about a 5% increase. We've had a gap for several years because our costs are so much higher than 5%. And, we're doing much better with this increase from the Medicaid provider fee that 42 hospitals got, not all of them, but 42, but we still have a gap that exists. So I'm going to ask Blaine to talk a little bit more specifically about the rural hospitals.
As Pat mentioned, overall, we are doing better. And one of the big wins, one of the most wonderful things that came out of the last legislative session that I wanted to highlight for all of you today was Senate Bill 241. As you may know, critical access hospitals are reimbursed by Medicare at their cost. And that is with the sole purpose of trying to keep rural hospitals open and alive in rural communities. But however, when Nevada created critical access hospitals and recognized it as a Medicaid provider, Medicaid has only been paying inpatient cost reimbursed care until now. And so with the passage of Senate Bill 241, for the first time in the state of Nevada, Medicaid is able to pay critical access outpatient care at cost. Now that state plan amendment was just approved about 20-ish days ago, right at the end of June. And so Medicaid, we're working with them to implement this. We're very excited, appreciative for that, all of their work, and excited to see the impact that this is going to have for our critical access hospitals. One other area I thought I would highlight for you all is rural health clinics. And I think Administrator Weeks talked a little bit about this and FQHCs, which are paid very similar to rural health clinics. This is one area, an opportunity that I think we could look towards. Unfortunately for us, some of the problematic language around payments exists in federal law. And so we're going to need to work with our federal delegation in order to make some changes here. But as you can see, the PPS rates that are paid to rural health clinics are not subject to rebasing unless authorized by Congress. So with rural health clinics now, this is where the vast majority of outpatient care is happening in our rural communities. So we're going to continue to look at our RHC reimbursement. And maybe there's some opportunities to work with Medicaid on supplemental payments or additional reimbursement structures there.
All right, thank you for that. Continuing, any more information we need to collect from you folks?
Yeah, we just very quickly, and I think again, Administrator Weeks went over Medicaid managed care very well and what the expansion in January of 2026 looks like for our rural communities. We're very excited to be working with them to address concerns, particularly as it relates to prior authorization, centralized credentialing, and some of the things we've mentioned.
All right.
I just want to remind everybody that whenever we're talking about Medicaid reimbursement, we are really talking about patient access to care. And Dr. Khan, you gave a great example with the physicians, pediatric physicians in the hospitals. To make sure we have adequate access, we have to reimburse at an appropriate rate. So thank you all.
With
Thank
that,
you
we'll
very
take
much.
questions.
I think
Thank
let's
you.
have the full presentation done. Anything else for a presentation from the Hospital Association or otherwise, then we can start the questions.
Yeah, I believe this is Joseph Filippi for the record. Marilyn Kirkpatrick, you have a question for Blaine or Pat?
I did, and thank you. And thank you for circling that back around about access to care, because that's really what we need to be focused on. At the end of the day, as a growing community, there's a big shortfall that we really got to talk about. So I want to ask a couple of specific questions, because for me, I tried doing the provider tax in 2013 with nothing but opposition, so I feel a little frustrated. And 10 years later, I'm glad it's done, but now we need to move forward. And there is only one county hospital, and I happily subsidize it $135 million a year myself, so I understand all of that. But let me ask a couple of specifics. So we talk about Medicaid rates, because you say 57%, but if we're paying, so that money's got to come from somewhere. But if you had a 57% increase on things, but if we're 96% of the Medicare dollars, is it more of a federal issue than a state issue, or is there specific things within a hospital that are costing more outside of like a NIC unit, right? I know a NIC unit is, but listen, I don't want to ever be the one to tell a mother that, I'm not going to do what I can to save her baby's life, right? So is there specific things within a hospital where the cost is driving up those rates, or where is the, I don't want to say lost leader, but where's the real issue within because my issue is we got to get back to primary care so that the ER doesn't become the primary care, right?
So you raise a lot of great points. So let me just say, when we talk about the hitting the 96% of Medicare, my guess is that statistics based on that we've just started this Medicaid provider fee program, and that's what's gotten us up to that level, because that is a big increase for hospitals. So we didn't have that before. Hey. Yes. Boy. Oh, okay. I'm sorry. I heard something else there. The other thing is, yeah, there are particular units. When you look at, as Administrator Weeks showed, when you look at Medicaid reimburses for about half of the births in hospitals. So, that is just a very expensive area. And unfortunately, when things get tough, that's the area that's cut, because that's usually a financial drain on hospitals, those units and things of that nature. So that's difficult. But I'd say you're asking about costs. One of the biggest areas of cost increases have been wages for hospitals. When you look at the increase in nursing wages and everyone else's wages, that's about 50% of a hospital's costs. And then also, if you look at drug costs, they've gone up significantly in the last few years, every year. So, I know everybody gets upset about hospitals and increasing costs, but we pass on a lot of the costs we receive. I mean, when you see your food bill, we pass on that cost, because your food bill is going up, our food bill is going up, our energy costs are going up, the drug costs are going up, supplies are going up. So, we pass that on to the consumer. Now, we unfortunately have to pass it more on to private insured individuals, because we can negotiate that rate. Medicare and Medicaid pay us a flat rate, and so we aren't able to pass those costs on directly to them.
Okay, no, I just wanted to maybe there's a way to dig down into some of that, but I think that, wages specifically comes under the workforce conversation as we have that later on. Thank you.
Commissioner Flo Khan, you have a question?
Yes, thank you. Just in terms of the unreimbursed care, when you were talking about the numbers and clearly the private hospital tax helped alleviate some of that burden, but can you say, are those costs going up? Are you seeing a rise in unreimbursed care, or has it kind of steadied given more people have insurance under the Affordable Care Act, and then of course the state taking action as well for eligibility to make sure eligibility has stayed the same? Can you just, I mean, what's that trend looking like?
So, the more people that have insurance, the less that goes down. One of the areas where we are seeing an increase is people who have high deductible plans. So a lot of employers are, giving their employees $5,000 or more deductibles, and they just can't pay it. I mean, it's just unrealistic, and we can't collect that. So that increases the unreimbursed care. I don't think it's going up dramatically, but I would have to look at it to give you a definitive answer.
Thank you.
Sorry, Dr. Khan, you're muted.
Sorry about that. Next person, commissioner in line for a question.
I'm not seeing any additional questions, Dr. Khan. I think we can go ahead and ask the Nevada State Medical Association to present next. Maybelline, are you able to pull up her slides?
Thank you, everyone.
Thank you both for your time this morning.
Thank you so much. Can you all hear me okay?
Yes, we can. Thank you.
Perfect. And thank you for running these slides. Good morning. Thank you, Chairman Khan, Executive Director Filippi, and the Nevada Patient Protection Commission for inviting us to present today. I'm Jacqueline Nguyen, Nguyen, Policy Director for the Nevada State Medical Association. We appreciate being able to give the physician perspective on Nevada Medicaid and have prioritized it as one of our top issues to improve access to quality care for patients in Nevada. Next slide, please. So Thank you. Established in 1875, the Nevada State Medical Association is the state's largest physician organization. Our members are physicians, residents, students, and physician assistants. Next slide, please. As you all know, when having any type of rate discussion, we must first look at the federal level, Medicare, since that is usually the benchmark that commercial payers and Medicaid uses. You'll see from the graph here, today, physicians are the only Medicare providers who do not receive an annual inflationary update. Newest data from the AMA now shows that from 2001 to 2024, Medicare physician payments have lagged 29% behind the rate of inflation. And that does not include the newly proposed cut to the Medicare physician payment schedule that was just announced a week or so ago. According to that new schedule, CMS is estimating a fifth consecutive year of Medicare payment reductions, this time by 2.8%. Next slide, please. So thank you to Administrator Weeks and the data from DHCFP. This page here, we're looking at Nevada Medicaid. We actually know that Medicaid payments have a direct resulting impact on access to care. And that's what we're hearing from our physicians as well. The commercial insurance data you see here is an example from a physician practice, but of course that will vary depending on the payer, their negotiated contracts, etc. The numbers below that show for Medicare non-facility payments, Nevada Medicaid, and Utah Medicaid is data directly from the Nevada Medicaid Access to Care Monitoring Review Plan for 2024. So 99211, 99213, and 99214 are common CPT codes. I won't go through all of it, but let's focus on 99213. 99213 is the code for an office visit for an established patient for 20 to 29 minutes. If you look here, you'll see for a 99213 visit, commercial insurance pays $127.36. A Medicare non-facility payment is at $91.15, and the Nevada Medicaid pays $35.79, and Utah Medicaid pays $66.08. You can see that these rates vary wildly and gives you a very good picture of why taking Medicaid is a challenge for physician practices. The comparison shows that it's not sustainable for practices to see large Medicaid populations. In fact, one of our physicians says that when doing a rough estimate of costs for his practice, he actually loses money on each 99213 visit through Medicaid. The bottom line is at the very least, we need to close the gap between Medicaid and Medicare. And more than that, research shows that closing the gap between Medicaid and private insurers would absolutely reduce the disparities in access to care for adults and eliminate those disparities in access to care for children. Next slide, please. So I appreciated that Patrick and Blaine were able to calculate their costs. However, for us, it's more challenging to get specific data on costs to run a medical practice because there's so much variation between specialties. However, medical practice is basically, right, a small business. So most of us know the struggles of operating a small business. While physician reimbursement rates remain suppressed, independent physician practices have seen overhead costs rise year over year. MGMA's poll in 2023 found that on average, operating costs for medical groups rose 12.5% nationally annually. Those numbers are even higher in Nevada. A brief survey of our private practice physicians told us that here on fixed overhead costs, we saw building occupancy or rents rise 2 to 4%. Utilities rose 15 to 20%. Business insurance rose 20 to 25%. I think it's the same with the hospitals. Employee wages are a big driver of our overhead costs. So here you'll see that office staff salaries and mid-level staff salaries also rose 8 to 10%. Health insurance and benefits for employees also rose 8 to 10%. However, there are also unique costs that medical practices must incur to comply with laws and regulations. For electronic medical record systems, the cost of a practice buying and maintaining an EMR system is astronomical. Also, we've seen that practices have incurred increased costs for rigorous cybersecurity and IT support to protect patient data. And of course, the final thing that I'd like to address on this slide is the issue of physician medical malpractice insurance, which for 2021-2022, the AMA reported that many policies increased as high as 10%. I'd also be remiss if I didn't mention AB 404. With the passage of 404 last session, we anticipate med mal insurance rates to go up. What that bill did was it took our 2023 malpractice cap of $350,000 and mandated an $80,000 annual increase until 2028, when the new cap then will be $750,000. Something worth noting as well, we've already shown that there's no inflation adjustment in any payer systems, Medicare, Medicaid, or private insurance. However, even in AB 404, there is a statutorily built-in inflation calculation of 2.1% annually beginning in 2029. Therefore, we anticipate the more than doubling of the malpractice cap plus the built-in inflation percentage will make malpractice insurance even more expensive for physician practices. So what you see then is that the low Medicare and Medicaid reimbursement rates, coupled with the rising cost of doing business in Nevada and even just inflation, makes it untenable for physician practices to operate. Next slide, please. So while you see that reimbursement rate is a priority, there are other obstacles to Nevada Medicaid, to physicians taking Medicaid, specifically the administrative burdens that we've been talking about all morning. Certainly appreciate Administrative Weeks' slide number 23, which recognized some of the burdens, which could be alleviated by centralized credentialing and streamlining prior authorization. Prior authorization challenges, our physicians are saying, eats into their time, staff time, and resources and is an added cost to the practice. There's frustration with the back and forth with submitting for prior authorization, where practices experience high claim denials and lengthy resubmission processes. Plus, in some cases, even receiving prior authorization does not necessarily mean you'll ultimately be paid for the service you already rendered. The Dunn paper found that the national average loss on a Medicaid claim, that's the sum of processing the cost for the physician and the risk of having to abandon the claim, is a loss of about 18% for Medicaid compared to 4.7% for Medicare and 2.4% for commercial insurance. This is even more cumbersome because the complex system of prior authorization for fee-for-service and MCOs each differ. And again, we appreciate all the efforts that will be made to streamline this. So we ask that fixing prior authorization is a priority. Next slide, please. So we did a survey of our members, and these are a few of the additional responses that we received regarding challenges they face in taking Medicaid. So a lot of our physicians talked about network adequacy and the ability to join the panels, non-uniform credentialing processes for Medicaid fee-for-service and the MCOs, and then the credentialing process that's cumbersome, protracted, or ambiguous. They also tell us that there's delayed payments in Medicaid. Certain specialties like OB/GYN don't even receive payments until the end of their term of care, which is 9 months. There's a higher rate of claim denials, and there's also an inability, just because there's not enough providers taking Medicaid, there's an inability to get patients appropriate workups because other providers don't take it or their wait times are too long. Next slide. So you'll see here some overlap of concerns from this slide and the last. A frustration that's expressed by patients as well as physicians is that Medicaid patients lack social services such as social services support such as transportation, care coordination, etc. That means it leaves patients frustrated and they don't pursue care because it's a complex system to navigate. The lack of social services also impacts physicians because that means that the Medicaid patient population has higher incidence of cancellations and no-shows, of course, adding to disruptions of patient flow and costs to a practice. Next slide, please. So the bottom line is this: when there's not enough physicians taking care of our Medicaid population, there's delays. And delays means that there's more complicated and expensive care. Low reimbursement rates means that doctors won't come to Nevada to practice. You saw from the Access to Care Monitoring Review Plan the difference between our Medicaid rates versus Utah's. Costs are rising in Nevada and physician practices will close if reimbursement rates remain low. Finally, it's not just that you lose your physicians, further exacerbating the physician shortage, but you lose the benefit of the economic impact of these physician practices as well. Again, remember, a physician practice is a small business. They rent office space, they employ mid-level providers, they employ office staff, billers, coders, janitorial services. In 2018, the AMA did an economic impact study analyzing data from 2015. At that time, it showed that Nevada physicians created a total of $10.9 billion in direct and indirect economic output. On average, each physician had an economic impact of over $2 million. That study also showed that physicians supported over 61,000 employees' jobs, each physician supporting about 12.08 jobs. They calculated that on average, each physician supports more than 1.1 million in total wages and benefits to employees annually. And I assume that these numbers have only increased in the last 9 years. Therefore, a challenged Medicaid system not only harms patients, physicians, and physician practices, it also has a negative impact on our community. Next slide, please. So we ask that we tackle these problems in a twofold manner. First, absolutely, we are asking that we need to close the gap between Medicaid and Medicare payments, and we understand that this is complicated, as seen from Administrator Weeks' presentation. We also need to ensure, though, that we ease any administrative burdens to physicians so they spend less time with paperwork and more time with their patients. We're asking for help to decrease prior authorization burdens, decrease denials, eliminate CPTs that have high auth percentages, streamline the process for prior auth and credentialing. And then final slide. So I hope I kept it under the 10 minutes, Joseph. So again, thank you so much for the opportunity to present. My contact information is here. The Nevada State Medical Association, myself, and all our members are really eager to be a part of the solution to ensure that patients in Nevada have access to the highest quality care. Thank you, and I can take any questions.
Thank you. Dr. Khan, I believe you're muted, sir.
Thanks for reminding. So, a couple of points I'd like to make. Number one, keep in mind the rates of reimbursement that you just heard. The highest was 127, and the lowest was Medicaid of $35. We all know an electrician and a plumber doesn't come to your house before he gets 150 for showing up or $200 just for showing up, and the work is extra. This is an embarrassment for a medical profession being reimbursed, whatever the reasons. But it's about time, in my humble opinion, that we as a state take this seriously. For the amount of time a physician spends of his life, 10 years plus, getting education, residency, et cetera, et cetera. So that's one area. The other area, in looking at reimbursement, we talk about Medicare as becoming the standard. We also heard that Medicare reimbursement is on cost basis. Most private insurances, when they negotiate with the hospitals, they like to use that as a benchmark, and they're wanting to pay 10% below Medicare or 20% below Medicare, or maybe if you're lucky, 10% above Medicare. So that compensation from the commercial side is consistently going down. The doctors and the hospitals in particular have to try to make up their difference from the of loss from Medicaid and or Medicare from commercial insurances. And that is not happening much of anymore either. And the last but not the least is the burden of prior authorization. I'm not sure if our insurance commissioner is here today, but this would go to them. The number of prior authorizations that are being denied, I know that firsthand. I'm in this profession. I do now consulting for utilization services, is unbelievable. Patients belonging to acute rehab or long-term facility or a nursing home are invariably denied. And so the patient sits in the hospital because they are not safe to go home, but could go to one of these facilities. It's unbelievable. I see this every day. They sit on the request for authorization for 3 to 5 days. Most say they have 72 hours to decide. Some say they have 48 hours to decide. The patient sits in a hospital and eats up the services for free. Others will deny authorization for 7 or 8 or 10 days until the patient is now ready to go home, has improved. So this is a huge issue. I don't think we will be able to address this, but the commissioner, I think, needs to take a look at that. I'll stop there and let our commissioners ask the questions.
Dr. Bio Curry-Winchell, please go ahead.
Thank you, Jacqueline, for the presentation. You know, I really appreciated the journey that you shared about. We often hear about access being the biggest issue, but if that infrastructure isn't there to even meet the need of that patient and the access doesn't really provide that capital, then we're missing the boat. And so I always like to give an example. I have seen patients where they have my name on their card as their primary, and then as I'm working through seeing them, I can't get them into the specialty that they need. And then there's this stopgap of care because of the inability to find another provider who will see them. And often it is because of the reimbursement rate. And so when we look at that core piece and how that is stopping the care, it leads to the delayed diagnosis. It leads to the complications that add up the amount of costs that we're seeing. So I think it's really important to paint that picture. And I just share my story as a physician, how I do see those issues in respect to not being able to provide that care because we don't have that investment in the investment of that infrastructure. So thank you so much.
Thank you. Next.
Marilyn, excuse me. Marilyn Kirkpatrick, go ahead, please.
Thank you, Joseph. My hand won't change color, so I don't know if you see me or not. So I'm clicking 100 times. I have a couple of questions. So one, I feel like I seen one of your slides where that looked more like national data as opposed to Nevada data. Is that the case for one? I
It
serve
depends on.
on some national committees and I feel like I've seen that data somewhere.
Yeah, so the slide that we showed regarding Medicare obviously is national data and showing the trend of how it lags behind inflation. But then the other data that we showed regarding the CPT codes is from Nevada.
So, so let me ask this question. I think that Director Weeks kind of talked about some of the things that they've been working on, the prior authorizations and different things. So has your organization sat down with them to see, I mean, because there's a lot of, here's what I would just say to everybody on this. Being a former legislator, the more that we can do regulatory, the more that we can do that way, there's a lot less room for implementation errors, right? So when the legislature does it, we're not necessarily experts on how to implement it, and sometimes you leave out a key phrase that doesn't allow you to do things. So I'm just wondering, is that something that you've done or reached out? She's pretty good.
Absolutely. No, she's incredible. We actually had a fantastic meeting with Administrator Weeks going through all of this, and also offered the ability for us to help when they're doing the streamlining and so on, to guinea pig it out, make sure that everything works the way it should work for on the physician side. But absolutely, I think that we're all rowing in the same direction, and Administrator Weeks has been really fantastic about being open-minded and hearing from our members as well. We actually plan on doing quarterly meetings with our providers or our physicians to specifically look at different specialties and how they interact with Medicaid. So duly noted, Commissioner, and absolutely, we've developed that great relationship, and also with the PPC as well. Thank you.
Perfect. And my last question is this. So I don't disagree with on the insurance rates, right? From car insurance to health insurance and all those things. But working at the county, we represent the ERISA plans ourselves, right? Our self-funded trust funds. And we are seeing big cost in pharmacy bills as well as insurance cost itself. And so we do have to negotiate for the 10,000 people, how to get them good care without, unfortunately, what a lot of people are getting is catastrophic plans, right? So really don't use it unless you're at the end, right? So I do think that maybe there's a separate conversation to be had with the insurance commissioner to see if there's some things that we can do. It's been a long time, Mr. Kipper, I think, since we've kind of did a study on what our insurance rates look. I mean, some of these, we have one employee that we pay $100,000 every quarter for medication. I mean, so we'd love if that was way cheaper, but we have to compensate for that too. And I just think that in the legislature, when they start putting these mandates on all these different services that they want to cover, that we as a group have to kind of say this could be a 2% increase. This could be this, because and the only way we're ever going to keep up with commercial rates is if we raise taxes. And it's great for this board because healthcare is always exempted. But I could tell you, there's a whole bunch of other industries that probably don't want to go there right now because they're feeling some of the same costs. So just maybe an insurance separate dialogue the insurance commissioner could have, or maybe there's a bill to study ongoing insurance rates or something that doesn't come from this committee, because I think we should focus on healthcare.
And we do have Insurance Commissioner Kipper online. It looks like he has something to say in response. Go ahead, Mr. Kipper.
Yes, go ahead.
Thank you. Thank you, Mr. Chair. And for the record, Scott Kipper, Insurance Commissioner. And Marilyn, I couldn't agree with you more. I think we should have that separate dialogue and dig a little bit deeper into this issue, because it is vitally important for the overall wellness of our insurance marketplace.
And this is Joseph, and this is something where, if we can have that separate dialogue, but if the commission as a whole would like to have future conversations on this topic during public meetings with the Division of Insurance, that's definitely something that we can set up. Definitely something we can discuss further and possibly prepare for. Commissioner Peterson, you have your hand raised.
Yeah, just a quick question. I feel like whenever I read these materials, there's a lot around loan repayment for physicians. And I know that there are different programs available in Nevada. So I'm just kind of trying to sort through, are those working? Are physicians aware of those? Are there additional needs there? Just so that we're not replicating, or making a recommendation on something that's already existing to support.
So we didn't have loan repayments as part of this portion, but absolutely that's something that we keep an eye on, especially what was happening with the new regs with loan repayments for physicians going out into the rurals. So we would absolutely love to be part of those conversations, and we can certainly poll our members and sort of see who has sort of taken advantage of those, if they've had an impact on their decision to stay and practice, and so on. So absolutely, I think that that's something that our members can shed some light on as well.
Yeah, I think some of that information would be helpful, just understanding if they're serving their purpose or if there's, changes that maybe need to be made.
Yes, thank you so much.
Hi, this is Walter Davis. And we definitely depend on, as a FQHC, we definitely depend on those loan repayment programs. They do help, but again, it's not enough, of course, sometimes to keep them locally. And we find out that sometimes when the loan payments are forgiven and they go to another, they move out of state. So I think there's some more work that needs to be done.
Thank you. Joseph, how are we doing with our time?
I think we're about there, Commissioner or Dr. Khan. I don't see any other commissioners' hand raised. So Jacqueline, thank you for your time this morning. Really appreciate the information.
Thank you. And for the insurance commissioner, I would follow up later for a conversation.
Perfect. We can do that.
Absolutely. Thank you.
Thank you. So going to the next item on our agenda is item number 6, policy considerations for expanding graduate medical education, which is called GME in Nevada. So we have 25 minutes total for this. Joseph, do we have a representative from them, from Mercer?
Yes, I believe we do. Mr. Aaron William?
Yes, yeah, William Aaron. Hi,
William
everybody.
Aaron, sorry about that. Please go ahead and feel free to share your screen and start when you're ready.
Great, absolutely. Everybody, good morning. My name is William Aaron. I have the privilege of working with Mercer and of working with Nevada and Administrator Weeks and their fantastic team. I'll just echo as someone who has worked in a Medicaid program for a number of years in Tennessee and who now works with a number of other Medicaid programs. So for a lot of kudos for Director Weeks and her team, and we'll just echo those. Also with us on this morning from Mercer is Charlie Greenberg, another member of our team who works with Nevada. I'll be taking the first part of the presentation. Charlie will be taking the second part, and then we'll be glad to answer any questions that you all have. So as we get ready to dive in, let me see if I can advance this. Technology is not our friend this morning. There we go. So just very quickly, what we want to do is provide a little bit of background, just briefly address something I think most folks know already, which is what is actual graduate medical education. Talk a little bit about the accreditation process for GME and the associated costs, and then talk about the landscape in Nevada, talk about what we see looking at other states, and then what we were asked to share some promising practices. Obviously, we've got just a few minutes. We're trying to provide useful information, but happy to follow up, provide any additional information that to questions you all may have. So just a little bit of background. The Division of Healthcare Financing and Policy and Administrator Weeks engaged us to essentially take a look at the possibilities to grow graduate medical education to support additional physician residencies here in Nevada. And specifically, the division was interested in looking at primary care focused options in rural areas of the state, right? So two priorities, both primary care and in rural. We've heard this morning a number of you talking about rural and primary care, and that certainly is reflected here as well. The goal of targeting the expansion in those areas of the state is, I think, as again, a refrain we've heard a lot already today, is to expand access to care in those rural communities by allowing medical residents essentially to be present, to become part of those communities. What the data shows, and again, certainly it's not a slam dunk as already been discussed, but physicians are more likely to remain in those areas after training is completed. And our work here, this includes, but was not limited to, taking a look at environmental scan, having interviews with several stakeholders in Nevada, and doing a review of other state GME programs. So just very quickly, what is graduate medical education? So graduate medical education, the way that it was defined for the scope of our work, is actually, it's another part of formal medical education. It is most often hospital sponsored or hospital based, that is pursued after someone receives their MD or their DO degree in the United States. This process can include internship, residency, subspecialty, and fellowship programs, and is key to leading to state licensure, board certification, their specialties. We mention this here just because graduate medical education, I think for most folks, is sort of synonymous with physicians, but to note that there are options that were beyond the scope of what we were asked to take a look at, but there are options to look at other healthcare provider types as well as included in GME. So just very quickly, a very sort of high-level overview of the accreditation process and cost. The first of which is to note, as the state is considering its options around GME, is that, from essentially creating the program to having the first resident takes time. In fact, as we've looked around, it can take 2 and often 3 years. This is in part because programs have to go through accreditation. There is the American Council for Graduate Medical Education that has to essentially lay hands on and bless programs so that they can be accredited and meet those standards. And also because you have to put the infrastructure in place. At a minimum, GME programs require a program director and then physicians to serve as the supervising faculty for residents. So as we've already noted a little bit, part of the challenge is in recruiting physicians to the rural areas who would be willing to serve as the supervising faculty. Costs for this program, can be significant, right? And it's worth noting that they fall really into 2 categories. And this distinction is important because it makes a difference for what Medicaid can and cannot reimburse. There's startup costs, and then there's operating costs. Startup costs really are over, with one small exception we'll talk about a little bit later on, that unfortunately, at least currently, is not available to Nevada. Startup costs are not Medicaid reimbursable. You cannot put state dollars, draw down the federal dollars, and then reimburse providers for that. However, operating costs, ongoing costs of salaries, et cetera, are reimbursable. So there is a place, and I think Director Weeks referenced this in her comments earlier, there is a role for Medicaid to play, that Medicaid can play, in supporting and growing graduate medical education in Nevada. So let's take a little bit, just a very quick look, and there's a lot of data. We've pulled out just a couple of things that we wanted to highlight here. The first of which is that if you look at the past 10 years or so for Nevada and what is going on with GME, you'll see that there has been significant growth, right? From 82 physicians completing their graduate medical education in 2012 to 232 in 2021. That's a big growth, right? That's rapid growth. And while it's not an exact comparison, if you look at the number of active residents in the US over a roughly comparable time period, you don't see as much growth. What you see nationally is 31.6%. So again, it's not a strict apples to apples, but it's fairly close. It certainly signals that Nevada has been successful in growing its GME presence, its GME programs, its GME resources in ways that have outpaced national growth. Zeroing in on one of the state's priorities, we want to talk about primary care, right? Because it was about rural and it was about primary care. And if you take a look at the growth in physicians who complete their primary care GME in Nevada, that has been a key component, even a driver of a lot of the growth that's been seen over the past 10 years. From 46 physicians who completed their GME, primary care GME in Nevada in 2012, up to 126 who completed in 2021. So again, it's certainly not to say that all the needs are being met. Certainly don't want to suggest this, but want to make sure that folks understand that GME is a strong and growing presence here, and that primary care is a significant driver of that growth, as we've seen over the past 10 years for the state of Nevada. So we'll shift gears a little bit. I'll turn it over to my colleague, Charlie Greenberg, who will talk about our multi-state review and GME roles in Medicaid there.
Thank you, William. Hello, everyone. My name is Charlie Greenberg. As William said, we are colleagues with Mercer, working with the state of Nevada. So talk a little bit about what our review encompassed. We want to start out by saying that Nevada is not alone when it comes to workforce issues. Honestly, you can see healthcare workforce challenges across the country. The degrees might be different, but everyone has some sort of identified challenge. What Mercer did is take a look at the largely Medicaid GME programs in 7 separate states. And we tried to find some sorts of commonalities or interesting differences that could lead to lessons for Nevada. What we've seen is several states like to encourage GME for primary care providers or certain other specialties. OB-GYN is another one that comes to mind. And then other states do try to or have tried to provide preferences for training in certain locations. Rural areas, frontier areas have come up in other states during our review. Now, GME in Medicaid is a little bit awkward. In Medicaid, you pay for services, you're not paying for education. So what you end up having is whenever Medicaid pays for GME, it's tied to the utilization within whichever delivery system you're working in, be it fee for service or managed care. Just before this meeting this morning, I decided to go and double check something. I went on the Medicaid regs website and just searched graduate medical education, and you find one hit in all of the Medicaid regs to graduate medical education. It is something that CMS recognizes that they pay for, but the legal and regulatory background, putting to really pen in what is okay and what is not okay when it comes to GME doesn't really exist. So we can move forward one. So when it comes to GME and Medicaid, there are 3 particular states that we wanted to call attention to. The first was New Mexico. A couple years ago, they went through a process where they did a bunch of studies related to GME, and they launched this initiative that tried to support GME growth that involved legislation, a new state board, and a new grant program for GME slots. One of the things they attempted to do was get more explicit authority from the federal government to pay for GME training, graduate medical education training. But the particular request to the federal government was not granted. And this goes back to the general, I guess we could say, some discomfort that the federal government has in the Medicaid space funding graduate medical education training. Second state we want to direct your attention to is Florida. William made a reference to this earlier. Generally, we have not seen instances where Medicaid will pay for the startup costs for new residency programs. However, Florida in May of 2023 did get approval for what they're calling a startup bonus for certain Medicaid for certain residency programs. I believe it's primary care and OB-GYN in certain underserved areas. And it's a bonus of about $100,000 per resident. It's not the dollar amount isn't tied directly to the costs of the startup for a particular program. And the payment only occurs after accreditation and once services are starting to be provided. So while Florida has ostensibly a program to allow for Medicaid payments for the startup costs of a GME program or certain GME programs, the payments actually come after the point at which the GME program starts. So there still is some risk on behalf of those who want to start a new program. They have to put forward the effort, put forward the money, and then after accreditation comes, they can claim the startup bonus. Another state of note is Massachusetts. In Massachusetts 1115 waiver that was granted, I believe it is in 2022. There was authority for a loan repayment program using Medicaid dollars. It was a limited pot of funds. It was limited in terms of the types of trainees that those funds could be applied to. But we'll get to a little bit as to why the loan repayment program in Massachusetts might not necessarily work for Nevada. So we can go forward one. We've talked about this a bit already. There are a number of factors that states should consider when talking about creating a Medicaid GME program. And for Nevada in particular, there are several factors. The number one is, of course, the startup costs. A lot of those costs are related to individuals. Getting that program director on board, getting a program coordinator on board, getting the appropriate faculty to instruct the residents, and then the cost of accreditation. All that costs money. The amount of funding necessary to get a residency program up off the ground and past and into accreditation varies dramatically. What dovetails with this is recruitment of faculty support and program director support for each individual program, especially when you're talking about rural areas. If you're already in an area of a state that has some access issues when it comes to primary care physicians, and you want to build out a primary care physician workforce in that area, you first have to have a physician who's willing to provide training in the area. So you have a little bit of a chicken and egg issue there, where you want to build out the training in a specific area. You need someone in that area. You need someone in order to provide training for residents who are participating in that area, in order to create the providers to provide services in the area. So a little bit of a chicken and egg issue there. One of the issues that we've heard about in talking with some of the stakeholders was difficulty in attracting GME primary care residents to rural locations. A lot of times there isn't a clean match through the match system, and GME programs have to use alternative means to find residents. And then lastly, there's been a growth in private equity ownership of certain hospitals and their impact in local healthcare systems. And the alignment between the private equity ends and the healthcare systems ends might not necessarily coexist when it comes to the training of residents. We'll move forward one more. So when providing, if you're providing additional state funding in order to draw down federal match for net new residency slots, focusing on rural primary care, there are a few recommendations that I think we would put forward. They're fairly broad, but they're important to consider. First, in terms of speed and experience, if you build on existing programs, you'll be able to get more residents churned out in a quicker fashion. There's already a couple of rural GME tracks available in Nevada. And for the sake of speed, it's theoretically possible to just create new sites and build those tracks out to an even greater degree, as opposed to trying to build entirely new programs from scratch. The other thing we would recommend is that the state really think about what its goals are, what its budget is, and how those two interact. So how many residents do you want to support, and what kind of money do you have in order to potentially support that number of residents? What are the specialties that the state is really interested in? Obviously, primary care is one that we hear all the time. OB-GYN is another one that we hear about all the time. Behavioral health physicians are ones that we hear about frequently. And then which parts of the state that they would want to support. Obviously, the rural areas and the frontier areas are the ones with most of the concerns. But ultimately, I think the takeaway is the recommendations, the requirements should clearly reflect the state's priorities when moving forward with the Medicaid GME program. Lastly, we think, further investigation might be warranted. I know there's been some discussion about non-physician GME, and that wasn't necessarily in our purview right now, but that's something that we can take back and think about in the future. But as of right now, we think that a promising course of action is to see if the Florida startup bonus mechanism is something that could be implemented in Nevada. This will require work with CMS, of course. But since it got approved in one state, you have a leg to stand on to say, hey, you got it over here in Florida. Nevada needs this help as well. There's been a lot of talk about using Medicaid funding for loan forgiveness. And as we discussed before, in Massachusetts, it was approved. The issue that you run into when it comes to using Medicaid funding for student loan forgiveness is that, as far as we can tell, the only way to get it approved is through something called a Section 1115 waiver. Those are in and of themselves tricky, but more to the point, they require cost savings elsewhere in order to fund the new initiative that you're trying to get approved through the 1115 waiver. So if you really want to have loan forgiveness for medical trainees in Nevada, you could propose an 1115 waiver to get it done, but you would have to find some other part of the program to tailor to find savings in order to fund the loan forgiveness for the trainees. So there's a bit of a give and take that would be required for that option. And I believe that's what we have right now, and we're happy to take whatever questions you have.
Thank you so
Thank
much.
you very much. Just a quick question. Do you have data on how many physicians that graduated from UNLV and UNR? As you know, the priorities for Nevada residents to get admission actually stayed in Nevada after completing their residencies.
Dr. Khan, this is William Aaron with Mercer. That's a good question. We do have some data on that. I don't know the exact time frame, but I can tell you that although it varies some year to year, it tends to be slightly below half as an average over time. And what we see is that percentage changes dramatically between the southern and northern regions of the state. In that, the southern, more urban region of the state tends to do better at retaining residents.
So my understanding is it's below 50%, and I could be wrong a few percentage. So we are spending money on training these students for medical school, etc., and we're asking for more GMEs, and yet we cannot keep all those who are here already not coming back. So that is my concern. As I think GME is an important point, but if we have no way to keep at least 50% of them, by adding GMEs, they will all go back wherever. Here's what happens from my experience. They do the residency, they go out for fellowships, for specialization, and don't come back for various reasons. So how do we justify I'm for GME personally, but given this data, I'm concerned, should we not be focusing on what can be done to keep them here or incentivize? You're talking about bonuses for coming in, et cetera, and et cetera. So that's my question.
Yeah, and Dr. Khan, it's a good question. I will tell you, and I don't have the national data at my fingertips. I will tell you, I don't think that that rate of retention is uncommon. I don't think it's a Nevada phenomenon. So I think it's fairly broad, but I may be, again, I don't have that at my fingertips. And I'll tell you that part of the challenge is, as you heard Charlie mention, Medicaid dollars can be used to have to be tied to utilization. So for us to be able to and by us, sorry, what I mean for the state of Nevada, for example, to be able to use state dollars and pull down and match federal dollars, there are some significant constraints on what federal dollars can be used to do, as we've noted.
Okay, thank you.
And Dr. Khan, just in response to that a little bit, I do recall earlier Administrator Weeks' presentation when she touched on the loan repayment options. There is a potential to maybe tie any GME, loan forgiveness to requiring a resident to, remain in the community, following the end of the program, et cetera. So that's something that could be potentially pursued in Nevada to hopefully address some of your concerns on having them immediately leave after their program ends. But we do have a few more commissioners with their hands up. So let's go ahead and start with Andrea Peterson.
Yeah, just a quick question. So the efforts that were driven in Florida, did those originate with legislation or were those just driven by Medicaid?
I believe it was driven by legislation. But every state's different. It's possible that each state has general authority granted to the Medicaid agency in order to proceed with a program such as that. But I believe in Florida it was driven by legislation.
You don't know what that legislation might have looked like maybe then? Just wondering.
Offhand, I don't have it with me. It might have been through their budget now that I'm thinking about it rather than actual legislation, but we can try and find that and get back with you.
Great question. Commissioner Khan, Flo Khan, go ahead.
Thank you. I just had a question. I know we're talking about the possible use of Medicaid dollars for these GME programs. Have we looked at, is there a possibility to go through the Federal Department of Education and looking at for higher ed? Has that ever been done to use federal education funding for these types of programs?
Commissioner, it's a great question. I will tell you that, we did take a look at available federal resources. And I will say, given the complexity, scope, and scale of federal government, I can't promise that we got everything, right? But I'll tell you, we did take a look at the health aligned federal programs. Nevada is, and as we shared with Administrator Weeks and her team, Nevada, and Charlie, correct me if I'm wrong, is participating in one, but may not be in the other. And so there may be an opportunity there. The Department of Education is something that I don't know that they've got a footprint associated with this, but something we could take a look at.
One other thing we might want to do too is look through the Labor Department as well and see if there's anything available there. I know they do for apprenticeship programs, but there might be an opportunity to look at this as well through that scope.
Commissioner Khan, I don't know if education or labor had anything. Other parts of federal HHS did have some programs that we noted. One in particular, the Rural Residency Planning and Development Program that runs through HRSA. The other is, I believe it's a Teaching Health Center. Let me make sure I have this right. Teaching Health Center Graduate Medical Education Program. As far as I could tell, there weren't any Nevada sites that had been approved to participate in either of those programs. And I don't know if that means no one applied, but I couldn't see any actual Nevada site approved under those programs.
And Administrator Weeks, did you want to chime in at all?
Yeah, I just wanted to know, the reason we're talking about Medicaid here is because we can actually leverage 60% on the dollar. So the point of not always draining the education in other areas is that we can actually more than double the money that the state invests if you let Medicaid fund and drive some of the residency program. From our perspective, we can pay for the salaries and all the pieces we know providers often have challenges paying for. And I do think if with Medicaid dollars, we could tie it to an expectation they stay in a community after residency for at least 5 years. So I think that's the point of saying Medicaid can more than double your program.
You know, to your point, you know, the military, and I know that firsthand because I served on their commission for the healthcare for the federal government. They require 12 years before they fund their education, et cetera, et cetera. So to me, something similar to that, if not 12, like you said, 5, that will perhaps get better retention.
Great, thank you.
Go ahead, anybody else? Question?
Yeah, Flo, did you have any further questions? No, okay. Dr. Bio-Curry-Winchell, go ahead.
Thank you for the presentation. I appreciate it. I had 2 questions. The first one is when we talk about, of course, tying and having hopefully those residents to stay, I think a part that we're missing is often if there's an adage, you're willing to take things if you're happy where you work or you feel that you are represented in wherever you work. And so I think in Nevada, we are missing the link of really looking at how our population, we don't serve it technically with our level of providers. And so as we're talking about funds to keep somebody here, we also need to look at how we can diversify our population, our residents, our physicians, because I can tell you when I have different medical students looking around, seeing where they want to do residency, or when the residents are thinking about graduating, should I stay in Nevada? There's a lens of, is there cultural? Is there all of those pieces make it's a part of their decision. And so as we try to lift up and be equitable to all the programs that are trying to people in based on money, we can't forget that if we don't have a level of representation, we will still lose. Because if someone doesn't feel like they're going to be comfortable in that area, if they're going to have ties or connections, that could also be something that we haven't discussed. The other piece I wanted to add was, when I think of the ELCO program, I would love to hear, what are your thoughts on what happened in that situation? Here we had a program, a residency program in ELCO, and it was not able to sustain. And I don't know if everybody knows about that, but I think as we start to build and think about what we can do, there's so many lessons to be learned from a program that was started and it was intentional, it was in the right area, but it wasn't able to sustain.
Thank you. Any other hands up, Joseph?
Yes. Mercer, did you have any response to the Elko hospital program closure? Are you able to speak to that at all? Did your study review any of that information?
Yeah, thank you, Joseph. I will tell you briefly, we, as part of our stakeholder conversations, did interview Charlie. Which hospital was that? Sorry, I don't have it right.
Northeastern.
Yeah, Northeastern up in Elko. And our understanding is that that was a financial decision on their part.
Okay.
All right. Thank you.
Thank you. And yes, we did have Stacy. Sorry, did you want to respond?
Sorry, I think my understanding is we give them the infrastructure grants, which is what we fund, but we don't fund the salary. Hopefully I'm not frozen. We don't fund the salary and the indirect service costs, which is what we're recommending here with the Medicaid approach. So a provider that wants to do this would not only get the infrastructure funds, but we would pay for those residents. So hopefully it would not be a financial problem for these. It would help, I think, relieve some of the burden.
Thanks, Stacy. And then, yes, we have Commissioner Davis. You've had your hand raised for a little bit. Go ahead, sir.
Yeah, well, I'm very involved in that whole Elko site location because Nevada Health Centers we were the place where the residents attended. I think it was basically a overall infrastructure challenge in many ways, certainly on the hospital side, but also having faculty have the ability to they had to travel from UNR from Reno to Elko, and that was a challenge even for the residents as well too. Housing was another challenge, in the area. So you had those multiple situations going on. So when the hospital made their decision, we ultimately had no other resource, and so we had to, discontinue the program. It certainly is still a lot of work that needs to be done in that area. We are also looking at, developing once the hospital closed and decide not to continue with the service. We had a short turnaround time to look at a teaching healthcare center model. It was just too fast of a turnaround, and you're correct. The cost for the startup of doing that is a lot. Although I think we get, from HRSA, has a that component, but you get about $160,000 per resident. But the startup cost in getting that done is quite quite a lot to deal with. We do run a residency program here in Las Vegas through our partners is HRSA. I mean, the HCA is the organization, and so it's running pretty well. And we're looking to replicate that through a teaching healthcare center model once we can identify and find the infrastructure for the startup component of that. And no
Thank
one
you very
applied.
much.
I'm sorry. Just one more thing.
Okay.
Yes, no one decided to in Nevada through our Primary Care Association looked at others trying to create that the grant for that, but it is a grant, and because of the startup cost, no one decided to go after that grant at that particular time.
Thank you very much. I think in the interest of time, we need to move on. We have a lot more to cover. The big item is still to come. So,
Dr. Khan, if I might, just because down the road, I think we're gonna touch on this GME conversation further in the meeting. So it might be helpful if we just kind of ask a couple more questions. There's a couple more commissioners' hands raised.
oh, okay. All right.
On this topic,
That's
if that's all
fine.
right.
Yeah, absolutely.
Thank you. So, Marilyn, please go ahead. You're muted, Marilyn.
Sorry. So Florida did do theirs through the budget process, but they also intertwined with Medicaid, right? Because what happens today is GMEs is separated in an educational component as opposed to Medicaid. And I think what Director Weeks is saying is we have an opportunity to be innovative. I recently met with the Director of Labor, and he said that we shouldn't be building any more hospitals if we can't, get the workforce that we need. And so for GMEs, I for one am not opposed to paying for them, but tying it to $2 because Medicaid is dollars that are they're public dollars, right? So they're the people's dollars, so they should see what their return on their investment is. But so I didn't see you compare Rhode Island. So a lot of people are flocking to Rhode Island with the processes that they have in place. Is it the difference between a shingle and a big firm that's out there like a Kaiser or something different? What is the reasoning that they're flocking to some of those northeastern states? Do you know?
Excellent question. I would say we're not familiar in particular with what's going on or not going on in Rhode Island, but we're happy to look into it, see what information we can bring back for the state.
Well, I mean, when you look at Texas, New York, and Rhode Island, right, they have the highest investment and the highest people coming. They have the least amount of shortage, right? Everybody has a shortage, but they have the least amount. So I'd just be curious to what are they doing that's different, and why are people staying for the longer term?
Hopefully we can gather that information as we look further into this topic. Andrea Peterson.
Yeah, I was just going to ask, and I don't know if Director Weeks can speak to this, but just kind of to have clarity, is this something that needs to be driven by legislation, or is this something that can be driven by Medicaid?
Sorry, could you repeat the question clearly? So is
Oh,
it the
just-
legislation to
Yeah,
leverage
just trying to
GME
understand, is
funds?
this something,
Sorry.
yeah, that needs legislation, or is this something that Medicaid's already, trying to do? Do you need help from us, or is this something?
Well, yeah, I don't technically right now have the budget authority to spend money in this space. So that's one. I would also need, I think, to outline the purposes for those funds so they are protected from other things. And so I think, yeah, it's a bill around workforce and Medicaid investment. And whatever the state can invest into that fund that we can match. You could also bring in local dollars if they want to invest in some of their areas. You could also match it, have private donations, and we can get a waiver to use those donations as well to match. So there's some ideas I'm just throwing out there. William and Charlie will probably tell me later how hard that last part is, but we're not opposed to asking CMS. I would just note real quick, the CMS did come out with the federal access rule, and the more that they're making Medicaid responsible for access, the more we've been putting as states pressure on CMS to help us with workforce and to help fund GME and things like that. So they're open to being creative, and the staff know we need help with this. But
Thank you.
And
Thank
Director
you.
Whitley, did you have something to say?
Yeah, I want to maybe just put a finer point on what Stacy sort of danced around. I think Commissioner Peterson, like, you're looking for a direct answer. Do we need a bill? And the answer is yes. It needs to be in Medicaid's budget in order for her to leverage the funding. And I do think in this discussion, leveraging the ability to match with federal funds is the key here. And I don't want to lose the opportunity for that. So just to be specific to your question, and
I really appreciate that. Thank you. Thank you very much to both of you. I appreciate it. Thank you.
Thank you. Joseph, do you have anybody else so we can move forward?
Yes, Dr. Khan, a couple more. Bethany Sexton, please go ahead.
I know through Renown, we certainly have heard from the Dean of UNR School of Medicine that one of the key components to keeping people in area is actually some of the fellowships. So beyond even some of the residency training, thinking about those additional specializations. And so I know that there are stats out there, at least locally, but also wondering if Mercer has any of those from a more national perspective about when you have medical school training and then you have residency and then you have fellowship, as you have that pipeline, how does your percentage of keeping people in the area increase? And so that might be helpful as we're thinking about how do we allocate those dollars, because that actually potentially gets people to stay in state.
Yep, thank you. I'll just say the reasons that people stay and the reasons they go are not always clearly documented. I will tell you that we do have some Nevada-specific data that said that one of the largest, in some cases the largest, reason people go and stay is family. And in the face of that, it's kind of like, well, great, either you got it or you don't, right? But certainly that's something we can do some more digging on.
Thank you. Commissioner Flo Khan.
Yeah, just following on Andrea Peterson's and Whitley and Stacy's comments. When you said, okay, we need authorization, and the funding, what do you, in terms of funding, as we're potentially looking at BDRs, what would that number look like for funding?
Richard, I'm just going to say, yeah, you want to go, or do you want me to? I think my advice is you leave it blank and let
I think that the bill directs us to leverage funding, because I heard psychiatry and OBGYN mentioned specifically. Well, we have other funding sources too that could, like opioid settlement funds could be utilized for that. But certainly gestational exposure to substances, psychiatry, definitely. So I think there are other funds, but I'd hate to limit it. But just matching what we currently have and leveraging that would be an addition. And so I think being specific in that area and the movement, but then directing us to challenge other funding, because that's what happens sometimes in government. We categorically address things, and that's what's happened here. There's been there hasn't been discussion with Medicaid about how to draw down a federal match and really leverage these because of where it's located, I believe.
Thank you for that. Marilyn, did you have something to say?
Well, I was just gonna say, I kind of go back to when, as we get to the point to talk about BDRs, the broader and the more autonomy that we can give to agencies to or direction to go do things, the better off, because otherwise you'll end up at IFC all the time. You'll end up cutting when times are tough, and so I would never like to put a dollar amount in, because President Sandoval, when he was the governor, we put $25 million into GMEs when UNLV Medical School opened as a start, but then it's never gone anywhere, and we randomly picked that number out of the hat from what the feds gave us, right? So so we didn't take away from the UNR program. So I mean, if we just talk about letting Medicaid do some of these things, and then they can be innovative and creative instead of tying their hands to something, but having an accountability piece, I think we'll move mountains a lot faster, is my only opinion.
Thank you.
We have one more comment or question from
Yeah, I think we
Commissioner
should
Wendy.
make it the last one. I'm
Okay,
afraid
let's do
it's 11:30.
last but not least. Wendy, go ahead.
Thank you so much. As I listen to this very rich conversation and all the contributions that have come from everybody and the thoughtful questions, I just wanted to give a big shout out and pat on the back to Stacy and Richard. I mean, she's under you, but Stacy, your can do, let's make it happen dialogue, and the invitation for us to be supportive of that potential is very, very encouraging in government. Thank you.
Thank you, everybody. So we have a long discussion coming up now and a couple of agenda items. So Joseph, next item is item number 7, submitted policy recommendations to be reviewed by us. Joseph, you want to take that?
Yes, Dr. Khan, thank you. Joseph Filippi for the record, and I'll try to move through this item quickly and then open it up for you for discussion. And then finally, we'll start talking about our BDRs next. So agenda item 7 is to potentially discuss any of the policy recommendations that have been submitted to the PPC. So as you know, we've released 2 different solicitations to the public to provide. One was to provide recommendations related to healthcare workforce, and the other was specific to Medicaid, asking healthcare providers to provide recommendations on how to improve the provider experience with Medicaid. And so we have provided a summary of all of those to you, everything that's been received thus far. This slide is just providing a quick overview of the 35 submissions related to workforce that we've received. Not a ton has changed since last meeting. We have received a few more submissions. As it shows here, a majority still relate to insurance and increasing reimbursement rates. After that relates to access to care and then licensure requirements. And I'll just note at the bottom, we did receive recently some additional responses related to provider wellness and mental health, which I think was brought up during public comment today as well. And so the other solicitation related to Medicaid. So as of Friday last week, we've received a total of 16 submissions. The majority do relate to the reimbursement and the billing process. And the rates specifically. Following that, it relates to a lot of what's been discussed from Administrator Weeks and others today regarding, the credentialing process, the prior authorization process, and then finally limitations on sessions for providers. So the more detailed list has been shared with commissioners. You should be able to see that in your packet. At this time, really, this is just an opportunity for commissioners to discuss any of the recommendations that have been received. We can then request additional information on a specific topic if you'd like for the future. But I will go ahead and just open it up to the group. Marilyn.
Thank you, Joseph.
Sorry. Looks like a couple commissioners have their hands raised. Marilyn Kirkpatrick, you want to go ahead?
Thank you, Joseph. And I know I'm probably driving everybody crazy, but I feel like we're finally in an opportunity to move the state on healthcare. So, I mean, if we're talking about BDRs, I think for sure that we have to have something, and we only have to do broad, and we can figure out the details in the next few weeks, I think. Because they're not actually due till September 1st, but I'm assuming the governor's office probably wants them a couple weeks to review them. But I for sure would want to do to look at Medicaid reimbursement and prioritize or look at what that looks like. GMEs would be a second one for me. And then a third one would be very broadly breaking down barriers for workforce, because I worked super hard to pass that bill last session, and it took me 10 years to do it. With Terry Reynolds and I spent the last 5 years on the licensing to get under B&I, and I want to reach out to them and see. But those would be my recommendations in a broad perspective, and then we drill down as a board to kind of figure out what that looks like. Because I think a lot of the ones that I've seen, they could go into more than one. They can go into a bill draft, and they're a lot of the same topic. But if we're broad enough, then we could maybe accomplish a couple of things at once. So
we have the next item is all discussion of all these potential BDRs.
Oh my gosh, I'm so excited. I just want to jump into it.
I think we are all excited trying to make a difference. So if there's nothing else on this information that Joseph shared, we could move on to the real substance and the meat of today's meeting. Is the item number 8 for possible action, is review and discussion of possible bill draft requests, topics, and we have not allotted a time, but I see it's 11:30, but hopefully in the next hour, we can wrap it up, and we may end up, just a word of caution, depending how the discussion goes today, to wrap up, we may have to have an additional meeting to complete the recommendations, because as Marilyn knows best, it goes to the Legislative Council Bureau, the AG's office chimes in, and the language gets tweaked back and forth. So September is pretty close. So the sooner we can narrow down our bill draft and the language, the better the chances of us meeting that deadline. So having said that, Joseph, you got the polling from the commissioners and the priorities. You'll take it up from here, please.
Thank you. Yeah, I'll just go directly to the poll results. Again, Joseph Filippi for the record. And so since our last meeting, commission members submitted a total of 13 potential BDR topics for consideration. Following that, a web-based poll was distributed to you all, and it asked you to identify the top 3 topics that you are interested in. So of the 9 voting members, we had 8 responses, and those responses indicated that there was 3 topics of interest for the majority to consider. So that's not to say that these are the topics that you all have to move forward, but just based upon this initial poll, these were the topics. So topic number 1 was requesting Nevada join the Interstate Nurse Licensure Compact and study the impacts of the state's nursing workforce. So this topic does relate to the governor's executive order, which asks the PPC to provide recommendations on how to remove unnecessary state administrative hurdles to recruiting and retaining healthcare providers. It was submitted by Bethany Sexton and Jalen Behunian, and this topic received a total of 4 votes from commissioners. So we'll go further into this, but just in addition to the Nurse Licensure Compact, I just wanted to notate a couple other considerations for you all. You know, depending on how broad we can make a BDR, potentially we could include different things related to nursing in a bill if that's what you decide to push forward. So just as an example, last session, Senate Bill 375 allocated $20 million over the biennium to support nursing schools in the state to assist with funding for their faculty and help them graduate more nurses. So that was one-shot funding that was provided to the nursing schools. And so there's been some articles and discussions on what to do once that funding ends, does that mean they're going to lose the faculty that they've now gained through this? So that's a potential area to look at. Additionally, we've talked about this in the past, but looking at providing the nurse apprenticeship with permanent funding to continue that grant-funded initiative, which is currently funded through ARPA funds. So those will end eventually as well. And then looking at just how to continue promoting nursing as a career in high schools and getting people interested in the profession at a young age. The next topic, which has been heavily discussed today, is relating to requesting Nevada to increase Medicaid reimbursement rates for physicians and other medical providers in key areas of need. So this topic does relate to the Governor's Executive Order Section D, which asks the PPC to identify a sustainable funding strategy for strengthening the healthcare workforce, which does include supporting competitive Medicaid reimbursements. So this topic was submitted by Chair Khan, and Marilyn Kirkpatrick received a total of 4 votes from commissioners. So something additional for consideration, I think this has already been discussed as well from Administrator Weeks, but looking at if we were to increase any rates or recommend that Medicaid increases any rates, looking how we can tie any increases to a priority that are in alignment with the access to care gaps in the state. So really making sure that any investments we provide have value attached to that as well. And then the last of the top 3 topics has also been heavily discussed, and I'm looking forward to this continuing, but looking at investing in graduate medical education to increase the number of primary care residency and fellowship programs throughout the state. So this does also relate to the Governor's Executive Order Section F, which asks us to identify strategies for evaluating new and existing state investments and efforts to improve the capacity and the size of the healthcare workforce. This topic was submitted originally by Chair Khan and received a total of 4 votes as well from commissioners. A couple of items for consideration, then I will open it up. So last session, SB 350 passed, and that provided funding, created a GME account, which is currently held under the Governor's Office of Science, Innovation, and Technology. And in addition to that, it established an advisory committee on GME to assist with prioritizing whatever funding is provided to programs throughout the state. So to my knowledge, that funding and that advisory council are still not up and running. And so a potential request in any BDR that's developed could be asking, giving DHHS some of that authority that was discussed and having them collaborate with OSIT and this advisory committee on increasing the number of programs and residents in the state. Additionally, looking at the GME funding opportunities, and then any additional fund, kind of as Director Whitley mentioned, just looking at other funding streams as well, the federal grant fundings, and just trying not to limit all the opportunities, but giving the state the authority to seek, any available funding. And then additionally looking at any loan repayment options for GME residents to keep them in the state following their residency end. Couple more slides and then I'll hand it over to the group. So I did my best of kind of evaluating these 3 topics and just touch on a couple things. So looking at the 3 topics, whether or not there was a potential high or low cost to the state. Again, as Administrator Weeks touched on, we have limited taxpayer funding. And so using those wisely. And then whether or not it would potentially be considered a long-term investment or a short-term investment. And then looking at if there would be rural or urban impacts to this potential topic as well. So looking at GME and any provider rate increases, those can both obviously be high cost areas. They would have longer term impacts, I believe, and would also impact both rural and urban areas. Related to the Interstate Licensure Compact, that's definitely a much lower cost to the state. I think the information we received from the nursing board said they would just have to pay an annual fee of about $6,000 to remain in that compact. It could be considered long-term, but potentially more of a shorter-term solution, as it doesn't necessarily grow the number of nurses that we're producing or retaining in the state, but it does allow easier onboarding process and improves licensure portability for nurses to come and go throughout the state. Final slide, and then I'll hand it back to you all. So BDR topics, some of the pros and cons that I initially just listed here. GME would definitely, would definitely increase the providers in the state and increase access to care. And then depending on how it's structured, we could have grant funding from the federal government and also that federal Medicaid match. And then hopefully we could be able to grow rural residency programs to address the rural and frontier access needs. A con, of course, would be high cost and taxpayer funding is limited. Same goes for any provider increases as well. But then related to the Interstate Nurse Licensure Compact, as I just said, it helps with streamlining the process and licensure portability, improves access to care, perhaps more so in some of these border communities such as Ely and other places throughout the state. But there has been, as far as a con goes, there's been historically strong union opposition to the compact, and the compact has failed over several legislative sessions in the past. So with all that information, I'm going to stop talking now. I'll open it up to commissioners to go ahead and start this conversation.
Thank you, Joseph. If I may, you've already highlighted the top 3 items that each had 4 votes, which is great. But with suggestion or input from Commissioner Kirkpatrick, you had recommended a topic recommending the Governor's Office of Workforce Innovation go and prioritize healthcare as primary industry for workforce development. I personally like that. Whether we can incorporate that thought, depending on how you feel, Commissioner Kirkpatrick, into one of the other BDR top 3 items that we have talked about in terms of workforce. Your comments, Commissioner Kirkpatrick?
Well, listen, I'm not opposed. I just worry. I know that the nursing compact will become a political football and a lost BDR. But I mean, there's no reason that we couldn't have a workforce broad bill and talk about, some of all of those, because I did think that the social worker compact might be something we want to look at. And I did think that there was the speech pathologist one. I mean, so maybe there's some other stuff that we want to look at, but if we leave it broad, then we can maybe give somebody the autonomy to go in and by regulation to establish some of these programs.
So in your experience, this Gowan could do that?
So Dr. Khan, to my understanding, and sorry to interrupt, the go-in recommendation actually could potentially could be gone. We could get that as a recommendation versus needing to use legislation for that. Because I believe the recommendation was just to ask go-in to prioritize the healthcare industry. And so because they're already, they've within their annual report identified that they wanted to focus on healthcare as part of 2 other areas that they wanted to focus on, we could just include that potentially from the commission in their annual report, asking go-in to prioritize healthcare. I'm not sure if that would take a legislative bill to do, but
All
just
right.
wanted to
That
touch
makes
on
sense. Yeah, that makes sense. And so we should. So let's proceed, open up for discussion from the commissioners, starting from the first item that we talked about, the nursing compact thing that Commissioner Kirkpatrick has already pointed out about the political nature of this subject, but let's start there and we can proceed further.
And perhaps it would be good to start with Bethany and Jalen, since this was your topic that you proposed initially, if you want to go ahead and speak to it.
Yeah, I'd love to jump in here. Just understanding the history, I would like to know maybe what could we do differently, seeing that there is strong union opposition, instead of continuing to hit our head against the wall, what could we present differently to maybe try to get some movement on that? That's what I don't know what to do there.
What is the co-sponsor's comment?
Totally agree. And I think from my lens, it's how could we put this in a way where perhaps we could overcome some of that? So I appreciated, Marilyn, your thoughts around the broader approach to some of the compacts. And I don't know the nature of, does it have to be a legislative act to join a compact, or could some of these licensing boards take that on in their process to join or not join? And so could you keep it broader and then sort of have them take that process on? That's a question.
And this is Joseph. To my understanding, a compact does have to be a legislative action. And there are several different legislators and other boards that have mentioned interest in compacts, the social work compacts, a lot of interest in that. I think the Rural Regional Behavioral Health Policy Board wanted to potentially use their BDR on the topic, but then there might be another individual legislator who wants to put that forward. So definitely a lot of interest in compacts in general. I'm not sure if there's, which we could potentially get clarification from the DAG or LCB on this, but I don't think you could have some sort of broad recommendation on compacts. It would have to be an individual compact by an individual bill, is my understanding. We do have, regarding the nurse licensure compact specifically, we do have Michael Hillerby. I see that you're on the call. He's the government affairs representative for the State Board of Nursing, and he was heavily involved in the last attempt of enacting the nurse licensure compact. Michael, I don't know if you can speak to this question at all.
Okay.
Yes, we can hear you now.
Where have you been, Mike Hillerby?
Good, Dr. Khan. Nice to see you. Yeah, I'm
Uh-huh.
happy to answer any questions. Again, as Joseph said, I represent the Nevada State Board of Nursing and have been working on the compact for a long time. So happy to answer any specific questions you have. In terms of Commissioner Bahunin, sorry, I hope we got your name correct. I would certainly love if there were any new ways to go about this. I think we've certainly presented answers to any policy questions that have arisen from the SEIU union who represents a number of nurses or other groups over the years. The core issue of the politics, the political football, as Commissioner Kirkpatrick mentioned, doesn't change. I'm always happy, even as an old dog, to try to learn new tricks. If there's a new way to do this or some other arguments, we're certainly open to making them, but that remains the key sticking point.
Thank you. So any other commissioners want to chime in? Because I have some thoughts, but I'd rather hear from others first.
Yes, Marilyn, you have your hand raised.
Well, and I wish we could just have a dialogue and maybe just say who we are as opposed to the hand raised thing, because I feel like we'll be going back and forth all day long. But here's what I would tell you, at least from my perspective, has always been the problem. We can do, and we've seen this during COVID more than ever on, we didn't have a bench. And crazy enough, we didn't spend any ARPA money to build a bench, right? In the grand scheme of things. So you're never going to get a legislative group to agree. They're not going to, and Mike, you can agree to this, I'm sure. You're never going to get this to be something that you leverage somebody over, right? That you're going to hold the budget if they don't do this, or you're going to do this, which is why, we wanted to move. We worked for 10 years, Maggie Carlton and I, to get that bill passed last time to move licensing as a whole to B&I so that it could all work faster and by regulations. But I mean, for the compact, if you want a compact to exist, I would tell you in today's environment is worse than when Senator Raggio and I worked trying to get something like this done. You got to build a bench. So when you prove that we're building a bench at the same time, needing people from the outside coming in, I think you'll go a lot farther. And the other thing I just want to point out is during COVID, we paid 10 times high amount for nurses coming in than any other state in the country. So that's fresh in a lot of legislators' minds. So I'm just seeing, for me, I would leave it broad so that we could give ability to, one, maybe go study it, because if 48 other states are doing it, why are we so different? Well, the reason we're so different is because we don't have a bench, right? So it's competition, and it won't force us to build a bench. So maybe there's another way to go after it that way. Nursing got much better during COVID, but maybe it's maybe if once you put in a bench, then people will be more likely to do it. But I mean, that's the problem in Nevada. We continue to go outside, and then we don't have people here. And then the people come here, we train them, and they leave, right? We got to figure out how to build a bench so that in 10 years there's long-term nurses. And we tried looking at, we got rid of LPNs so that we could have RNs, and we did some of those things. So that's just a little bit of history on why it's always a political football. But I bet, Mr. Hillary, you have some more insight.
Thank you, Commissioner Mike Hillerby. You're correct. The bench, as you call it, in really all of the health professions is a serious issue, but it's not unique to Nevada. Our numbers, the total nursing workforce, physician workforce around the country, serious issues. There were some meaningful investments made last session by the legislature in improving additional funds for nursing education. I think you'll see some more work toward that this next session. And if I may say, I represent two healthcare licensing boards, nursing in addition to pharmacy. Nursing right now, and typically licenses in about 4 days. So it's a very, very quick process. And while the boards are sort of an easy target because there's this very visible process in licensing, the larger issue you hit on is we need to be having discussions with kids who are in middle school about why to pursue STEAM and related in science and healthcare education, making the decisions they need to get into college programs, talking to state nursing programs about acceptance rates, about how much more funding they need to expand that. We need to build a workforce. We can license them very quickly with most of the boards. That's not the issue. The question is, as you well put it, the workforce, and why are people choosing other jobs? They do require a fair amount of education and high academic marks. So those are real challenges, and we need to look at that entire pipeline.
Any other comments from commissioners?
Wendy, go ahead.
Well, I was going to talk about the GME, but on this very same subject, I remember when I was Deputy Director, Department of Veterans, meeting with Kathy Denauer and the board on this very same subject. And I do feel we shouldn't give up on it. I couldn't agree with everybody more about the bench. I've always preached bench. You got to have depth. But I'd like to still continue to somehow bring common sense to the decision making of the nursing compact.
Other comments?
And let's go ahead and, if it's all right with you, Chair Khan, as Marilyn kind of suggested, just leave it open, like an open discussion at this point. Feel free to just chime in. It seems like we're kind of focusing on the nurse licensure compact at the moment, but we can kind of talk about all of these different BDR topics that have been kind of shared as well. So, Jalen, I know you've been.
What I would suggest, though, on this nursing compact, since there are multiple opinions and views and some concerns about it getting anywhere, I would request all the commissioners to think about language, perhaps. If it is not a BDR, what can be done to address the issue and how? Is a commission recommendation, like we talked about the other subject, or is there a way to make the language such which is acceptable to most? If we can give it some thought, we can come back to it and decide whether there is good enough language that potentially would be acceptable to the legislative process. And if not, then whether we should consider that as a recommendation. Does that make sense to everybody?
So Dr. Khan, you're seeing that maybe people can think about it and then we can push it as a recommendation, and if other legislators want to pick it up or whatever, then we can work. Yep.
That's what I'm thinking.
Is it possible to see what has historically been submitted?
Yep, we can pull that. I can help get that, or Joseph can, off the legislature website. You can go back to almost every session for 12 years. See what's been submitted.
I thought I shared it previously, but I can definitely make sure that you each see that bill again. But yeah, it's been submitted, 3 sessions now, and it hasn't passed, I think more than one hearing. So, and I know that, we received, it should be in your packet, a lot of the information from the board and related to, just their responses to some of the opposition from unions in the past. And so tried to provide as much information regarding the topic to you all ahead of this meeting as much as possible. But definitely we can look at that previous legislation again. Jalen, did you want to chime in?
Yeah, thank you, Joseph. I just needed first to let you know that I do have a hard stop at noon, so unfortunately I will have to drop off. But I did want to ask Mr. Hellerby, do you know if other states like California, Massachusetts, New York that have strong union presence, have they been able to get this legislation through, maybe with that clause about strikes? Do you know the answer to that?
Yeah, thank you, Mike Hillerby. And if you look at the map of the nurse licensure compact, and we'll get an updated map to Joseph, they can share with you. I believe we're at 41 states and 2 territories have enacted the compact. You'll see a hole in the western United States, Oregon, California, Nevada. You'll see some more on the East Coast in historically very strong union states. It has moved recently, most recently last year in the state of Washington. One of the concerns unions have raised is, could this be used to make it easier to hire quote unquote strike breakers, to bring people in the case of a labor shortage? I won't go into the details about why the compact really doesn't matter. We've talked about that at legislative hearings, and there's details on that. What they have done in some other states is added some requirements that if hospitals bring in people under using a compact license during a labor action, that they report that information to the boards, so that data is available and we can go back and see. Again, as you see in the response from the National Council of State Boards in Nursing, there had not been any data historically that proves that, but if that was something that we wanted to see here in Nevada, that's the idea of something that can be done. Like all compacts, the core pieces of the compact must be passed the same in each of the states in order for it to operate. But there are things you can do around the compact that aren't considered quote material deviations that can work. So data collection, things like that can be done to help provide some evidence about what has and hasn't worked.
So I think since I have seen the information, Joseph, you sent, that we can all revisit that, perhaps till we get that perhaps modified language or some other form and decide as a recommendation or otherwise. I think we should proceed to the next item on the potential BDRs, which is regarding the Medicaid reimbursement. To summarize, as we heard in the presentations and everything else, and as we all chimed in into that, it seemed to me that there is not a consensus, but generally speaking, everybody feels that the reimbursement needs to be addressed, et cetera. So I'll open up for discussion if somebody has some specifics. If we are going to go that route of BDR, how do we put it in language and go from there? I'll open it for discussion.
Dr. Khan, it's Marilyn. I just think that the language this time we should vote to move forward a BDR that does Medicaid reimbursements with a targeted process, or so that we could actually go and look and maybe talk to Stacy and see what some of those are and maybe what the cost could be, right? So we have to figure out that. But I mean, going forward, Medicaid reimbursements with a targeted audience or just Medicaid reimbursements is actually good enough. And then we can work with maybe Director Weeks and figure out what those costs might be, because that's going to be the answer that the governor's going to ask, I'm sure, and the legislature.
So I like your suggestion. So if we want to move forward, perhaps we take, if you put it as a motion, we can get a second and vote on it, and then proceed with all the questions that you raised to receive cost, et cetera, and then try to tweak the language as appropriate for the Legislative Council Bureau. So do we have a second for this? Do you make it as a proposition here?
Yeah, that's my motion.
Okay, and the second.
And this is Joseph Filippi for the record. Before we move forward with that motion, just wanted to let you know, like, as you talked before, you have opportunity, one more meeting potentially next month to finalize your BDR topics. So if this is a topic you want to just, vote to move forward officially today, that's fine. But we do have a month between now and then where I can go ahead and request additional information from the department and Medicaid if you're wanting to come up with, targeting any increases to align with access gaps, and then maybe coming back to you all with a list of some provider types to consider. And then, moving forward next month, that's an option. Or as you are wanting to potentially do today, just voting on the topic today. And we can kind of, once we have a topic identified for the BDR, really the in the weeds language and everything, as we kind of talked about, can be done after that. It doesn't have to be done during a public meeting on the specific language of the bill, but just the overall topic and what we're wanting the bill to do ultimately, which is what we need the PPC to consider and vote on.
Yeah,
So
I believe we should, in my opinion, at least, we should proceed with this because this will take more than 2 meetings by the time we send it as a recommendation for a BDR, and then we'll come up with what needs to be into that BDR, and we will debate that one, and then it'll go back for the Legislative Council Bureau. So we'll take 2, if not 3 meetings to finalize the final language. But as a subject, if we believe that this is should be one of the BDRs, then Joseph, you can collect all the information and potential information, and we can then get that at the next meeting and then review that and add or subtract from all that area that is pertinent or not pertinent. That would be my suggestion. So in that context, do we have a second to consider this as one of the topics for BDR to proceed for more information?
I would second it. I think that it'll put a lot of people at ease that we're actually looking at that because this is the number one topic, and I think that it gives us time to drill down on it.
Right. So do we have a second?
I believe Marilyn just seconded.
Okay.
Well, I think he was thinking I made the original motion and he was
Yes.
just second, and it's crickets. Somebody, it was 16 of everybody's ideas. So-
This is Walter Davis. I second.
All right. So let's put it. Anybody opposed to considering that as one of the BDR items?
Hi, this is Lauren Driscoll from the Attorney General's office. I'm just wondering, can you guys clarify the title of the topic that you're moving for, just so we have that on the record?
Joseph, that's your job.
Yep, you got it. So I think the request is, excuse me, let me pull it up again. So in looking at the top, recommending as one of your BDR topics to increase Medicaid reimbursement rates for physicians and other medical providers in key areas of need. And in that, requesting the Department of Health and Human Services and Medicaid provide information between now and our next meeting to help provide a potential list that you all can look at and review to hopefully provide a ranking and prioritize any rate increases to align with access to care gaps in the state. Does that sound about right?
Yeah, but that's not what she's looking for, right? You're looking for the one sentence. So the one sentence is to Medicaid reimbursements with a targeted approach. I think is what she's looking for, right?
Perfect.
And the AG.
That works for me. I just wanted to clarify because we were saying move for that topic. So I just wanted to get the topic title in there. Thank you.
Okay, great. Thank you very much. I think that is good. So we'll follow up at the next meeting. So the next item